evening, ladies and gentlemen. Thank you for logging in early today. Welcome to day 2 of Challenges in Managing Lymphoma in 2022. Today is 12th of September and day 2. We are very honored to collaborate with Mumbai Hematology Group, which in last many years have been able to bring so many international speakers, now not just for India, but throughout the globe. And the person who is responsible to do it is the person who you see on the screen, Professor Dr. M.B. Agrawal. An institution in himself, inspiration to all of us, teachers of teachers. No wonder, sir, that you get so many accolades, including the inspiring hematologist of the country. May I request you, sir, to take it forward from here.
Thank you, Dr. Manoj, for those kind words. Good evening to everybody from India, and good morning and good afternoon if you belong to other parts of the world. Challenges in managing lymphomas in 2022 with 15 international guest speakers. We began yesterday and will continue till Thursday. These are our 15 very esteemed guest speakers. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, the Executive Committee of Mumbai Hematology Group, all our faculty members who are extremely prominent leaders in their own fields, all our discussants who are eminent hematologists or medical oncologists from India, you participants for sparing your Monday evening, morning or afternoon. The website of Mumbai Hematology Group is very simple to remember, www.mhg for Mumbai Hematology Group. So that's mhgindia.com. You can visit this, there is no password needed, and you can have all the future academic activities of this body at your fingertips. Today is day 2, and we've got 3 fantastic lectures coming up. The first one is on PET scan, the second one is on newly diagnosed DLBCL, and the third one is on relapsed refractory aggressive lymphoma. It's my pleasure to introduce our guest speaker, Dr. Andrea Galemni from France. He's Professor of Hematology, Research and Innovation Department, A. Lacassen Cancer Center at Nice, France. Earlier, he was head Hematology Department and Bone Marrow Transplantation in S. Crozet Hospital. And prior to that, he was Associated Professor of Hematology at the University of Sophia Antipolis, Nice, France. He has had a very illustrious career spanning over 45 years, during which he has received various awards and occupied various positions at national and international level. He has published 6 book chapters, 173 articles, all in peer-reviewed journals, with 15,749 citations, H-index 60, I-10 index 140. He's a reviewer for various international journals, including Nature Reviews, JCO, JCI, Lancet Hematology, Blood, Annals of Oncology, Leukemia and Lymphoma, Hematologica, and Journal of Nuclear Medicine. He's going to lecture today, and his lecture is entitled Role of PET Scan in both Hodgkin and non-Hodgkin lymphoma. Sir, thank you very much, and over to you. We can see your screen, sir. Go ahead.
Good afternoon to everyone. Thank you very much, Dr. Agarwal, for the kind words. Thank you very much to the Mumbai Hematology Group for the kind invitation to this very interesting international workshop. And thanks also for the title assigned to my presentation. Those are my COI disclosures. Well, What are the reasons of the success of FDG PET-CT in lymphoma? Here, the first reason is the very high FDG fluorodeoxyglucose avidity of non-Hodgkin and non-Hodgkin lymphoma. Here on the top, you can see here the FDG avidity of the most common lymphoma subset. And as you can see, more than nearly all the subset are FDG avid in more than 50% of the cases, with the exception of mantle zone or marginal zone extranodal, MALT, and cutaneous lymphoma. On the bottom slide, you can see here the SUV max of the different lymphoma subset and their breakdown in 4 major categories. The most avid are aggressive lymphoma, and among them diffuse large B-cell lymphoma, peripheral T-cell lymphoma, Hodgkin lymphoma, Burkitt lymphoma, and primary mediastinal B-cell lymphoma with SUV max in average of 19.6. Intermediate high activity is for mantle cell lymphoma and follicular lymphoma with the SUV max ranging between 8.7 and 7.7. Intermediate low affinity for FDG, nodal marginal zone lymphoma, splenic marginal zone lymphoma, and MALT lymphoma, 3.8. And last but not least, low affinity small lymphocytic leukemia, chronic small lymphocytic lymphoma, chronic lymphocytic leukemia, SUV max 2.5. The second reason is the availability of modern, fully integrated PET-CT scanners, which are able to produce in a joint imaging session co-registered images on CT and on PET, thus increasing the highly increased anatomical details of the lesion and their relationship with neighbor organ. First, patients undergo CT scan in 2-3 minutes, and then followed by PET scan in 20-25 minutes. The third reason is the very high overall accuracy of FDG PET-CT. As a matter of fact, this an innovative imaging technique combines a image tool which a very high specificity, which means very low false positive results, with a very high sensitive technique as PET is, with very low number of false negative results. As a result, you end up with a combined modality technique which has a high accuracy, which is the sum of high specificity and high sensitivity. The fourth reason is limited to interim PET scan during treatment and in some lymphoma subset which are characterized by a predominant microenvironment, such as Hodgkin lymphoma, primary mediastinal B-cell lymphoma, follicular lymphoma, and some cases of diffuse large B-cell lymphoma. As you can see, at disease onset, there is the neoplastic clone in the center in red, and there is a surrounding huge micro environment accounted by non-neoplastic cells, which are switched on by a cytokine network produced by tumor itself. And here, if we consider the case of Hodgkin lymphoma, you can see that after only 2 cycles of chemotherapy, most cases of Hodgkin lymphoma are cured, and the neoplastic burden is shrinked, and the surrounding non-neoplastic microenvironment has been switched off. In minority of cases, on the other hand, which is 15% of the cases in average, the neoplastic population is chemoresistant, and few surviving cells are responsible for maintaining on the non-neoplastic microenvironment, so thus increasing the ability of the tumor to concentrate still FDG. So, in other words, the microenvironment in several lymphoma subset works like a hi-fi amplifier in hi-fi sound reproducers to amplify the signal of persisting viable neoplastic tissue. As a matter of fact, FDG PET-CT has become a new standard of treatment in Hodgkin lymphoma. As you can see, it's proved to play a definite role in during first line, before, after, and interim during treatment, during second line treatment, before and after therapy, before and after radiotherapy, before and after autologous stem cell transplant in second line treatment. As a consequence, several PET-guided strategies, PET-adapted strategies, are now the standard of care in several countries all around the world, and some of them have adopted this PET-adapted strategy as a guideline treatment for Hodgkin lymphoma. On the other hand, there is no role at all for FDG PET-CT in the follow-up of patients due to the huge number of false positive and cost-effectiveness of this program. Probably there is an exception during immune checkpoint inhibitor treatment, in which probably FDG surveillance PET could play a role, as we can see very soon. Here you can see the results of PET-CT staging in a large cohort of 1,100 patients enrolled in the British Rattle study, which were staged on clinical grounds and on CT, contrast-enhanced CT scan. As you can see, as a result of PET staging, 20% of the patients had their stage changed. 14% were upstaged and 66% were downstaged. The main reason for upstaging was extranodal disease spread in 3/4 of the cases, and nodal spread in lymph node with a normal size, which underwent undetected by contrast-enhanced CT scan. And the most frequently involved extranodal site in up to 80% of the cases was the bone marrow. I tell to you that FDG PET-CT cannot discriminate between pure bone or bone marrow invasion. Here you can see an example, very clear, of the Hodgkin spread in the body of the second lumbar vertebra, which went undetected by CT images and which was clearly visible in the PET-CT. But a question arises. What is the interpretation key for bone marrow invasion by Hodgkin lymphoma? In these large retrospective studies, 108 patients with advanced stage Hodgkin lymphoma enrolled from Italy, Denmark, and Poland were lumped together in a single study. And you can see here that 50% of the patient had no uptake at all at the level of bone marrow, while 29 of the patient had a non-focal bone marrow FDG uptake with an intensity higher than liver. The treatment outcome of those patients, of these two cohorts of patients, was superimposable, with a 3-year progression-free survival of 82.5%. On the other hand, patients showing a focal bone marrow FDG uptake, defined as an FDG uptake with an intensity higher than liver, visible in at least 2 PET slices, had a much worse outcome with a 3-year progression-free survival of only 66.7%. The author concluded that only focal FDG uptake could be an harbinger of the disease spread to bone marrow in Hodgkin lymphoma. Here I can see on the right, on the top, an example of diffuse FDG uptake in all the spine. On the bottom, you can see a focal FDG uptake in the context of the second lumbar vertebra. New aspect, innovative aspect of PET staging in baseline PET staging in Hodgkin lymphoma. Total metabolic tumor volume and tumor distance. Here you can see a graphic Gaussian spatial distribution of photon emitted by a single FDG-avid focal lesion in relationship with the intensity of the emitted positrons. Upon setting an arbitrary threshold for SUV, for example, SUV equal or higher than 2.5, and upon counting the positrons with SUV max between SUV between 2.5 and SUV max, you could end out with an approximate dimension of the volume of this single nodal, of the single Hodgkin or non-Hodgkin mass. On the other hand, if you measure the positron emitted with low intensity and with higher standard deviation in blue, you end up with the so-called partial volume effect, which described the penumbra of FDG all around the single nodal mass, which does not account for the volume of this mass. So this is a concept underpinning the reason of choosing a threshold for SUV while measuring a metabolic tumor volume in lymphoma. Briefly, all the FDG-avid tumor masses could be automatically contoured by a dedicated software, for instance, the Fiji software. The areas of physiological FDG uptake, brain, myocardium, kidneys, bladder, bowel, are manually removed. Then an algorithm starts to compute MTV counting to start MTV procedure in the so-called process of tumor segmentation, which consists in drawing a three-dimensional map of every single voxel measured inside the contoured mass in the three dimension of the space. Thresholding, as I mentioned to you, only voxel with a SUV between SUV max and SUV threshold are computed to correct for the partial volume effect. The threshold could be a fixed percentage of SUV, for instance, 41%, or an absolute value, for instance, SUV higher than 2.5 or 4. The counted voxel are transformed in volume unit, cubic centimeters. The sum of all computed voxel allow the calculation of metabolic tumor volume, and all the metabolic tumor volume are summed up in a total metabolic tumor volume value. Total lesion glycolysis is computed by multiplying a metabolic tumor volume by the SUV mean of all the lesions. Here, as a proof of concept, you can see the consequence of MTV, metabolic tumor volume, total metabolic tumor volume counting in baseline in a cohort of 59 all-stage Hodgkin treated with ABVD plus or minus radiotherapy. And interim PET was assessed not with the Deauville 5-point scale, which is the most common way of interpreting interim PET scan, but with delta SUV max. And the TMTV was assessed with SUV max threshold of 41%. As a consequence, you can see that patients having low metabolic tumor volume and negative interim PET scan had the best outcome, while patients having a high metabolic tumor volume and a positive interim PET scan had a worse outcome, with intermediate value for patients having either of both values. This is just a proof of concept, but we will see that till now, no clear clinical fallout of this novelty could be used in clinical practice. A second very important new metric is the so-called tumor spread, or Dmax, which is deemed to portray the ability of the tumor to spread all over the body. Is, in other words, a surrogate of an arbor staging. A Dmax is defined as the longest distance in centimeter measured between pixels belonging to any couple of sites, nodal or extranodal, detected upon tumor segmentation along all the paired lesions of lymphoma spread. You can see here on the right, for instance, that in this case, the Dmax is the longest distance from the two more distant sites. We were able to check on clinical grounds the meaning of Dmax measuring in a baseline PET of a cohort of 331 patients with advanced stage Hodgkin lymphoma and a negative interim PET enrolled in HDO607 trial treated with 6 ABVD cycles. A single experienced nuclear medicine physician calculated TMTV at Dmax. Median and average Dmax values were 12.5 and 15.3 centimeters. In multivariate analysis, including all the demographics, clinical parameters of the enrolled patients, as well as TMTV and Dmax, only Dmax with a cutoff value of 16.2 centimeters turned out significant in predicting relapse, with a hazard ratio of, for a high Dmax, of 1.46. Upon combining Dmax and IPS, International Prognostic Score, 0, 1 versus 2 or more, in a two-factor predictive model, 3 categories of patients with a statistically different treatment outcome, P to -4, have been identified. Both low Dmax and low IPS, 9% of the patient in a 3-year progression-free survival, 100%. Either high Dmax and low IPS or low Dmax and high IPS, 60% of the patient, 3-year progression-free survival, 88%. And both high Dmax and IPS, 3-year progression-free survival, deceivingly low, with a PFS of 72 at 3 years. What is the meaning of this study? If you consider, for instance, the long-term follow-up of patients with advanced stage Hodgkin lymphoma, a negative interim PET scan treated with 6 ABVD courses, as this one in the SWOG S-ALL-816 trial, the 5-year PFS was only 76%. On the other hand, if you break down the patients according to Dmax and IPS, you could conclude that patients having both high Dmax and IPS 2 or more than 2 have a deceivingly low treatment outcome with ABVD, and they deserve another treatment for their lymphoma. Another very challenging issue: is possible to meet radiotherapy in early stage favorable Hodgkin lymphoma? This, we are still in the field of PET-guided treatment of Hodgkin lymphoma. Yes and no. Let's see. Here you can see the classic prognostic factor of early stage disease. Large mediastinal mass is shared by the three main groups: EORTC, German Hodgkin Lymphoma Study Group, and Canadian Hodgkin Study Group. Age higher than 50 or 40, erythrocyte sedimentation rate higher than 50, 4 or 3 involved nodal regions. If all these criteria are absent, the patient is in favorable disease, while the presence of just one of them indicates an unfavorable disease. You know, you all know the results of the very important innovative trial, rapid trial, in which 602 patients with stage 1 to A, non-bulky, without extranodal sites were enrolled, and patients were treated with 3 ABVD courses, and interim PET scan was performed afterwards. Patients with a positive PET scan were treated with 1 more ABVD plus involved field radiotherapy at the dose of 30 gray. On the other hand, patients with a negative PET scan defined by Deauville score of 1 and 2 were randomly allocated to continue with involved field radiotherapy 30 gray or no further therapy. The trial had a statistical design of non-inferiority with a non-inferiority margin for no further therapy of delta -7%. As after 3 years of follow-up, the 3-year progression-free survival for patients treated with combined modality was 94.6, and the 3-year progression-free survival for patients addressed to no further therapy, 90.8. But the 95% confidence interval fell astride the non-inferiority margin of -7%. So the non-inferiority could not be declared, and the primary endpoint was not met. However, if you consider overall survival of those patients, something should be discussed. This is something which should be discussed with the patient, just to remind us that we are not treating a disease, but we are treating patients, and with the pros and cons of different treatment approaches. Here you all know the results of the H10 trial. Involved more than 1,500 patients all around Europe. Here you can see the standard arm for the favorable patients. 465 patients enrolled. Patients with were randomly allocated to a standard therapy with 3 ABVD cycles plus involved nodal radiotherapy, whatever the results of interim PET scan, while in the experimental arm, patients treated with 2 ABVD and interim PET scan was performed afterwards. Patients with a negative interim PET scan were matched to the standard therapy in a non-inferiority trial. Patients with a positive interim PET scan were compared, were treated with 2 BCOP escalated plus involved nodal and compared with the standard arm in a superiority statistical design. The first sub-study, the endpoint of the first sub-study was not met. You can see here a 5-year progression-free survival for 99 versus 87, while the superiority study with 2 more BCOP escalated involved nodal radiotherapy, the endpoint was met. Here again, the third negative study in the early favorable Hodgkin lymphoma patients, again, 1,000 patients enrolled. Those are the classic number of the German Hodgkin lymphoma study group. Patients were randomly assigned to standard therapy with 2 ABVD plus involved nodal, and patients are addressed randomly to the experimental arm, were treated with 2 courses of a BVD, and interim PET scan was performed afterward. Patients with a negative interim PET scan were addressed to no-forte therapy, while patients with a positive PET scan were addressed to involved nodal radiotherapy. After a median follow-up of 47 months, the patient treated with combined modality had a 5-year estimate of progression-free survival of 93.4, while patient treated with chemo alone had an inferior outcome with only 86.1% of 5-year estimate of progression-free survival. The non-inferiority margin was set at delta of -10%, And here you can see here that again, the 95% of confidence interval fell astride this non-inferiority margin, and again, the non-inferiority could not be declared. We should stress, on the other hand, that in those, among those patients classified as favorable, there were 30% of patients aged higher than 60, B symptoms in 10%, and bulky in up to 18% of the patients. New frontiers, again, of PET scanning is the use of the value of MTV in on a cohort of 249 stage 1-2B French patients included in the H10 trial and treated with a standard therapy with 3 ABVD plus involved nodal radiotherapy. You can see here that patients with a low metabolic tumor volume, less than 147 cubic centimeter, had a 5-year progression-free survival of 95, while patient with a high metabolic tumor volume, interim negative PET scan had an intermediate outcome, and patient with both high metabolic tumor volume and a positive interim PET scan had the lowest treatment outcome with a 5-year progression-free survival of only 25%. So this is a very important information. And now I'm proud to present you the first trial in which MTV is used prospectively in early Hodgkin lymphoma. Patient stage 1A, 2A without bulky disease and without extranodal sites are stratified according to the risk of treatment failure, according to modified URTC criteria, MTV value at baseline, and interim PET after 2 ABVD courses. Low-risk patient, group 1A, favorable according to modified URTC criteria in which the bulky was taken over by a large nodal mass of 5 centimeter, low metabolic tumor volume, and negative interim PET. High risk, either a positive interim PET or high MTV, intermediate risk, low risk patient with unfavorable MRTC criteria. And here you can see that the patients enrolled in this large international study, enrolling patients from Poland, Italy, France, Spain, and Switzerland. Patients are treated, are scanned at baseline, and MTV is assessed at baseline. Patients are treated to ABVD, and interim PET scan is performed afterwards. Patients with a negative interim PET scan and low metabolic tumor volume are stop here the treatment if they have an early favorable disease, or continue with 2 other ABVD if they have early unfavorable disease. After chemotherapy alone, they are addressed to a stringent follow-up every 3 months for 3 years, with cell-free DNA assay every 3 months for the first year and every 6 months for the second year. In case of reappearance of cell-free DNA or increase of the baseline value, a PET scan is performed, and patients with a positive PET scan are addressed to involved nodal radiotherapy and maintenance treatment with nivolumab 24 doses. The same triple therapy, chemotherapy, involved nodal radiotherapy, and immunotherapy is administered to either PET2 positive patients or patients with a high metabolic tumor volume or patient relapsing with after chemotherapy alone. Here you can see the schema of cell-free DNA monitoring during the first years and during the second year. And the results of this preliminary results of this study will be presented in oral session during the International Symposium of Hodgkin Lymphoma held in Cologne in the forthcoming October. What the role of PET in early unfavorable Hodgkin lymphoma? Please look at the end of therapy PET scan. Here, because there is a sort of preliminary results of a pilot study conducted by Memorial Sloan Kettering, Stanford, City of Hope, and Rochester University, 4 cycles in the United States. Patients with at least one unfavorable criteria were treated with Adcetris plus AVD for 4 cycles. Patients had end of therapy PET-CT. Patients with a negative end of therapy PET-CT were addressed to 4 different regimens of radiotherapy. 30 gray involved side radiotherapy, 20 gray involved site radiotherapy, 30 gray with cardiovascular protection radiotherapy, or no radiotherapy at all. And you can see here, only after a median follow-up of two years, the 2-year progression-free survival of patients treated with chemo plus chemotherapy alone with AVD had a progression-free survival superimposable to that of patients treated with combined modality. And this is very, very encouraging for the change of strategy in early unfavorable Hodgkin lymphoma patients. The same results, similar results have been obtained by the German Hodgkin lymphoma study group. Briefly, again, large number, 1,100 patients were randomly allocated between a standard treatment for the German Hodgkin lymphoma study group with 2 escalated BICO plus 2 ABVD followed by the involver-free radiotherapy versus an end of therapy PET-adapted strategy with 2 cycles of BICO escalated followed by 2 ABVD. An end of therapy PET scan was performed. Patients with a negative PET scan were addressed to no further therapy. Patients with a positive non-therapy PET scan were addressed to involved nodal radiotherapy. Again, the endpoint was a delta inferiority 5-year progression-free survival of delta of -8%. And here you can see that 5-year estimated for the standard combined modality was 97%, for the PET4 guided treatment group 95%, and the endpoint was met. So the authors concluded that radiotherapy could be safely omitted after 2+2 regimen with 2 BICOP escalated and 2 ABVD. What about advanced stage Hodgkin lymphoma? Here you see 2 studies running in advanced stage Hodgkin lymphoma, sharing the backbone of the study, stage 2A till 4B in the rattle, stage 2B to 4B in the Italian HDL 607 trial, 2 cycles of BVD, and interim PET scan performed afterwards. In the English trial, PET negative patients were randomly assigned to 4 more AVD versus 4 more ABVD. Patients with a positive interim PET scan were addressed to 6 courses of BICOP escalate. Patients in the Italian trial were treated to a BVD and interim PET scan was performed afterwards. Patients with positive PET scan were randomly allocated to 4 BICOP baseline, 4 BICOP escalated plus 4 BICOP baseline, or the same regimen supplemented with rituximab. Patients with a negative interim PET scan kept straight on with ABVD, and if the end of chemotherapy PET was negative, they were randomly allocated to no further therapy or consolidation radiotherapy. Here you can see the results of the Rattles trial. Patients with ABVD treated continuing with ABVD or AVD had no difference in outcome between those 2 subgroups. 3-year progression-free survival 85.7 versus 84.4. Patients treated with BICOP 6 courses because of positive interim PET scan, and the 3-year progression-free survival 67.5%. In the Italian study, patients with a negative PET scan, interim PET scan, who had their treatment with 6 courses of ABVD had a 3-year progression-free survival of 87%, as compared to patients switching to BICOP escalated for a positive interim PET scan with 3-year progression-free survival of 60%. completely different approach by the German Hodgkin lymphoma study group, in which the standard of care is starting with 2 courses of BCOP escalated. The role of the downgrading treatment in interim PET negative patient. You can see here that patients with a negative interim PET scan, as shown by the Will score of 1 and 2, were treated with 6 courses for BCOP escalated or abbreviated courses of only 2 escalated BCOP. After a median observation time of 53 months, a patient treated with abbreviated regimen of escalated BCOP had a 3-year progression-free survival of 94.8 and a 5-year progression-free survival of 91.8, which was superior to the same figures for patients treated with 8 or 6 courses of escalated BCOP. The German colleagues concluded that abbreviated courses of escalated BCOP is the best therapy for patients showing a negative interim PET scan. Another similar but even less aggressive treatment has been tried by the French group LISA in HL 2011. Patients were treated in the standard with advanced stage Hodgkin lymphoma patients were treated with a standard therapy with 6 BCOP escalated in the standard arm versus interim PET adapted therapy in the experimental arm, in which patients with a positive PET scan kept straight on with switched to BCOP escalated 4 more cycles, and patients with a negative interim PET scan downgraded their treatment with 4 more ABVD. And as at the end of the study, there was no difference between the standard and the experimental arm, and the author concluded that downgrading the treatment is safe in patients with a negative interim PET scan after 2 BCOP escalated courses. Here you can see here totally new, totally different story. I think all of you know this innovative trial comparing standard ABVD for 6 courses with Adcetris 1.8 milligram by kilo in 1.2 milligram by kilo in the day 1 and day 15 in 6 during the 6 courses of ABVD in which bleomycin was withdrawn. So the ABVD versus ABVD. After a median follow-up of 73 months, the 6-year progression-free, the 6-year overall survival, for the experimental arm was statistically significant to the results of the same parameter in patients treated with a standard ABVD, 93.9 versus 89.4. There was also a difference in progression-free survival, which was also significant at 6 years. However, if we concentrate on the same trial with a shorter follow-up of 3 years, just because in this case, this study could be compared with interim PET adapted strategy, we can see here that patients enrolled in the experimental arm of the Echelon-1 trial had the same 3-year progression-free survival than PET2 negative patient who continued with ABVD. While patient with showing a positive interim PET scan had some improvement of their outcome thanks to the adjunction of Adcetris to AVD. So this could be a matter of debate and in some categories of patients with very poor prognostic factor, probably AVD is superior, at least in PET2 positive, to standard ABVD chemotherapy. Another issue very important is PET-driven consolidation radiotherapy in advanced stage Hodgkin lymphoma. I want to present you a clinical case. A male aged 38 years was admitted for fever, weight loss, and cough, and PET CT showed a metastatic bulky of 30/11 centimeters. The clinical stage was 2B bulky. The patient had an IPS score 2. The patient was in complete metabolic response after 6 ABVD, and both PET2 and PET6 were negative. PET2 and PET6 were negative. He was randomized in a further therapy arm of the HD-0607 trial that demonstrated no benefit for consolidation radiotherapy in patients showing a negative interim and end of therapy PET. You can see here the huge bulky mediastinal tumor, which was evident in the fused images and in the PET images. And here you can see the results of the entire cohort of 296 patients, no difference after median follow-up of 6 years, both in terms of 6-year progression-free survival and overall survival. No difference also according to the size of the large nodal mass, which was 5 to 7, 7 to 10, higher to 10 centimeters. Some trend toward to some benefit is observed for patients showing a classical bulky, but this was not statistically significant. The same experience in HD15 trial, enrolling more than 2,000 patients for Hodgkin lymphoma patients in stage 2B, 2, 4, 3, and 4, 3 different regimens of BCOP escalating. Restaging was made by CT scan alone. Patients showing a partial remission of residual disease with a diameter higher than 2.5 centimeters underwent the end of therapy PET scan. Patients with a positive PET scan were treated with radiotherapy 30 grays on residual. Patients with a negative PET scan, as well as patients without any residual mass, were addressed to simple follow-up. After more than 5 years of follow-up, you can see here that 1/3 of the patient had a residual mass, and 1/4 out of this third had a residual mass which was PET positive. In green, you can see the outcome of patients without any mass, residual mass, and in orange, the outcome of patients with PET negative residual mass, no difference at all in outcome. Patients with a PET positive residual mass had a slightly inferior 5-year progression-free survival. So the German authors concluded that thanks to the PET assessment at the end of therapy, radiotherapy could be delivered only on 1 out of 11 patients. Immune checkpoint role of PET during the immune checkpoint therapy. I will run a little bit because I am a little late. Here you can see a patient aged 37, which was staged to be bulky, and he was treated with 2 ABVD, and the PET2 turned out positive with a Deauville score 4. You can see here the interim PET of this patient. He switched his treatment to BCOP escalated 4 cycles to BCOP baseline 2 cycles in the HD-0607 trial. A third PET scan at the end of therapy showed complete metabolic response. The patient remained in complete continuous remission for up to 8 months till July 2015, when the first of long series of relapses was recorded. The first relapses was recorded in cervical and right mediastinal nodes here. Patients were treated with brentuximab vedotin 1.8 milligram by kilo for every 15 days, followed by FIM and autologous stem cell transplant. The PET-CT showed a partial metabolic response. As soon as the donor was available, an allogenic stem cell transplant was made from HLA matched sibling, and PET-CT showed a complete metabolic response. And 11 months later, a second relapse was recorded in nodes previously attained by disease, supraclavian right mediastinal nodes. Patients were treated with brentuximab vedotin for 4 cycles at the same dose than before. A PET-CT was made, complete metabolic response. The patients continued for up to 12 more cycles. And 8 months later, a third relapse was evident again in the right mediastinal nodes and the right lung hilum. Consolidation radiotherapy was given. The patient achieved complete metabolic response. But 5 years later, a fourth relapse was evident. In this time, the relapse was on the contralateral side of the mediastinum in the left para-aortic mediastinal nodes and the pylorus region. The patient started therapy with immune checkpoint inhibitor nivolumab, 240 milligrams every 15 days in continuous treatment. 3 PET scans during the first 14 months were negative. A PET-CT on months plus 19 showed the reappearance of mild focal FDG uptake in the left para-aortic mediastinal nodes previously recorded. The latter persisted in the following 4 scans with a waxing and waning FDG avidity. The last scan performed plus 29 months after nivolumab start continued to show, as you can see in the red circle, some avidity in the left para-aortic nodes in the, with the same intensity to that recorded in the first negative scan during nivolumab, consistent with lyric immune response type 3. You can see here the waxing and waning value of SUV max in the 4 PET-CT after the previous 3 PET-CT, which were negative. In last observation, the patient still in complete metabolic response. And you can see here the immune response, indefinite response, immune response 3, in which there is an increase, in which the situation characterized by an increase in FDG uptake in 1 or more lesions at any time during treatment, without a concomitant increase in lesion size or number, is consistent with patients still in remission. In conclusion, the introduction of PET-CT for Hodgkin lymphoma staging allowed to drop the last invasive staging tool, the bone marrow biopsy, and improve the overall accuracy in detecting tumor spread compared to contrast-enhanced CT scan. Metabolic tumor volume and Dmax are promising tools to portray tumor burden and spread in baseline PET. PET-adapted strategy in advanced stage Hodgkin lymphoma during frontline ABVD or BCOP escalated are now a standard of care in countries all around the world. Adcetris plus AVD proved superior to ABVD in advanced stage Hodgkin lymphoma, both in terms of 6-year progression-free survival and 6-year overall survival. However, this advantage was more evident in patients with a positive interim PET scan and extranodal and disease spread to extranodal site. Consolidation radiotherapy could be safely omitted in advanced stage Hodgkin lymphoma and a negative end of therapy PET after BCOP escalated or ABVD. I would add that consolidation radiotherapy could also be safely omitted in early stage unfavorable Hodgkin lymphoma, provided the patient is treated not only with ABVD alone, but some ABVD supplemented treatment with, for instance, Adcetris, without the need of consolidation radiotherapy. Standard Lugano 2014 criteria for lymphoma stage are not applicable for response assessment in Hodgkin lymphoma treated with immune checkpoint inhibitors. Well, I will switch rapidly to PET-CT in non-Hodgkin lymphoma. I have very few slides. I will hope to stay in time. Different from Hodgkin lymphoma, you can see here that PET-guided treatment for Hodgkin lymphoma is restricted to first-line treatment, where it proved to have a role in staging, interim, and end-of-therapy PET, and end-of-therapy evaluation, sorry. After first-line treatment, PET-guided radiotherapy has become the standard in several lymphoma subsets. Again, like in Hodgkin lymphoma, there is no role at all for PET scanning in the patient follow-up. And in the near future, PET-guided treatment based on metabolic tumor volume will be soon launched, provided we could pass by the hurdles of MTV standardization. PET-CT for staging of aggressive lymphoma, diffuse large B-cell lymphoma, mantle cell lymphoma, grade 3 follicular lymphoma, anaplastic large cell lymphoma. PET-CT at baseline provided a very high sensitivity and the same higher sensitivity than contrast enhanced CT scan and the same specificity to CT scan. The higher sensitivity was related for external site detection and in particular bone marrow, liver, spleen, and lung. PET-CT was able to upstage nearly 20% of non-Hodgkin lymphoma, aggressive non-Hodgkin lymphoma. Contrast-enhanced CT scan has no longer a role in most cases if staging is performed with PET-CT with or without contrast medium. Therapeutic strategy changed in 5 to 15% of the patient, especially, as we will see very soon, in follicular lymphoma. In follicular lymphoma, PET staging is mandatory to confirm truly localized disease to be addressed to radiotherapy. And in fact, PET was able to upstage it between 18 and 31 of all the patients with follicular lymphoma, but in patients with defined in early stage with CT, it was able to upstage up to 60% of the patients. And once again, this was because of detection of extranodal disease, mostly in bone, spleen, gastrointestinal tract, and skin. However, we should remember that in follicular lymphoma, the sensitivity for bone marrow involvement is suboptimal, is lower than in other aggressive lymphoma. Another issue very important is the relationship with histological grading. There is a poor correlation with SUV max on PET-CT. In case on watch and wait approach, however, an SUV max higher than 10 correlates with the need of starting the treatment within 6-12 months. Here you can see the relationship between patients staging with CT and PET in follicular lymphoma in which bone marrow biopsy was not done. And here you can see the relationship of PET staging and CT staging in which the bone marrow biopsy was done. You can see here that without bone marrow trephine biopsy, the upstaging of PET is able to detect twice more sites than CT staging. If, on the other hand, a bone marrow trephine biopsy is performed, PET-CT is able to upstage a number of patients much lower than PET-CT, than CT, sorry, compared to what was obtained in patient staging without bone marrow biopsy, which means that the bone marrow trephine biopsy is essential in follicular lymphoma to detect bone marrow spread. As far as the relationship between SUV max and histologic transformation, you can see here that the specificity of this relationship is low for values of SUV max of 10, increases of higher than 13, and is 100% in SUV max higher than 17. SUV max values lower than 12 are associated with a very low risk for histologic transformation. And nonetheless, however, due to the SUV max overlap values between the different cases, among different cases undergoing a histologic transformation, PET-CT cannot replace biopsy to confirm histologic transformation. However, in patients with inaccessible biopsy sites, if the SUV max is higher than 15, it may be reasonable to forego a biopsy and treat disease as histologic transformed without histologic confirmation. Here you can see in a large retrospective study the role of PET scanning for PET-CT staging and radiotherapy delivery in grade 1-2 follicular lymphoma before and after introduction on FDG PET staging. You see the number of patients addressed to radiotherapy that decreased dramatically. Baseline metabolic tumor volume is provided a very powerful predictive tool on treatment outcome in nearly all the lymphoma subset: Hodgkin lymphoma, diffuse large B-cell lymphoma in red, primary mediastinal B-cell lymphoma, follicular lymphoma, peripheral lymphoma. You can see here, however, the MTV value behaves as a continuous variable, and problems in methodology of MTV assessment as well as cutoff value prevent the use of metabolic tumor volume in clinical practice. It's just an example. You can see here only diffuse large B-cell lymphoma and the variation in tumor in treatment prediction according to the different methodology used for TMTV assessing. Very recently, in a very large cohort of 1,200 patients included with diffuse large B-cell lymphoma included in the PETRA consortium from 5 clinical trials, PETAL, HOVON 484, SAC, and the 2 English studies. IMPI, the so-called IMPI, International Metabolic Prognostic Index, outperformed International Prognostic Index. In this index, obtained with including MTV with a cutoff value of 307.9, which was not along a continuous relationship between prognosis and metabolic and total metabolic tumor volume, age as a continuous variable, and an ARBO stage 1 to 4, there was no longer a need to include LDH, extranodal sites, and performance status, and 3 simple variables, which was MTV as a continuous variable, age as a continuous variable, stage 1 to 4, outperformed EP both in 4 levels expression here on the center and on 3 level expression. So this should be still validated, but is definitely is an important step forward for standardization of metabolic tumor volume. What about interim PET in non-Hodgkin lymphoma? The interpretation key for interim PET is by semi-quantitative evaluation by SUV max, outperformed the pure visual assessment with 5-point scale of Deauville. You can see here patients with a cutoff between PET3 and PET4 enrolled in the French study. And you can see here the performance of delta SUV variation from baseline to interim PET, higher or lower than 70%. even more interesting is the double evaluation of MTV and interim PET. MTV with the methodology I showed you before, and interim PET with the Deauville 5-point scale. Patients with low metabolic tumor volume, whatever was the results of interim PET scan, had a very good treatment outcome. Patients with a high metabolic tumor volume, higher than 400 milliliters, had a much worse treatment outcome with a further substratification according to interim PET with a positive or negative interim PET. This is the experience of the English group. Here is the large German PETAL trial enrolling more than 900 patients with aggressive lymphoma, mostly diffuse large B-cell lymphoma. The treatment was started with 2 cycles of R-CHOP, and interim PET scan was performed afterwards. Patients with a negative interim PET scan defined as a delta SUV mass less than 66% continue with standard R-CHOP treatment. Patients with a positive interim PET scan were randomly allocated to continue with standard R-CHOP or addressed to a very aggressive Burkitt-like acute lymphoblastic leukemia protocol. 959 patients enrolled, 53 patients available for intention to treat analysis, 746 patients with which means 87% had a negative interim PET scan and 13% has a positive interim PET scan. In all, in interim PET positive patients are switched to the Burkitt acute lymphoblastic leukemia regimen showed no beneficial effect on treatment failure, CR rate, and overall survival. This is on the entire cohort of patients, but the same results were obtained when this analysis was restricted to diffuse large B-cell lymphoma. And I wanted to thank all of you for your attention. Sorry for this long presentation.
Thank you, sir. That was fantastic. Enjoyed it. I don't think we have had a better talk on PET scan in lymphoma than this any time in my life.
Thank you very much.
Crystal clear in the depth and so much of learning. So we have some of our colleagues over here. They may like to ask you some questions. We'll start with Dr. Krishna Ratnam.
Thank you very much, sir. The German trial which you alluded your last slide, is it based on the Deauville score or the MTV, the metabolic tumor volume?
No, the last trial I showed you, the PETAL trial, was only interim PET adapted trial, in which patients with a delta SUV max higher than 66% continued with R-CHOP, while patients with a lower reduction of SUV max switched to randomly switched to acute lymphoblastic leukemia regimen or continued with R-CHOP. And there was no benefit at all in increasing the intensity of treatment based on interim PET scan. But I understand your question, by the way, because metabolic tumor volume showed a much higher predictive value at baseline. So probably in the future, the trials based on metabolic tumor volume assessment at baseline will be much more yielding than those I showed you as in the PETAL study.
Can I ask one more question?
Yes, of course.
In your own practice, for early stage Hodgkin's lymphoma, do you give involved field radiotherapy based on the PET or you don't give? I mean, the PET negative cases. Do you give involved field radiotherapy or you just follow up?
You mean end of therapy PET?
In early stage Hodgkin's lymphoma.
But you mean based on which PET? Interim or end of therapy?
Interim.
So in interim PET, all the study I presented to you does not allow to omit radiotherapy based on interim PET. My feeling is that the end of therapy PET scan is much more reliable to guide radiotherapy, provided you give the patient something more than the standard ABVD. So, in other words, if you could deliver, for instance, in early unfavorable patients, 2 BCOP escalated and 2 ABVD, if the end of therapy PET is negative, you are confident to omit radiotherapy. The same if you deliver AVD plus brentuximab vedotin in the trial I showed you to you from US, you are confident that if the end of therapy is negative, you can omit radiotherapy. If you deliver only standard ABVD, for instance, 4 cycles of ABVD, if we speak about early unfavorable, or 2 ABVD, if we speak about early favorable, you are not that confident to stand up on to stay on the chemotherapy alone. In the trial that I showed you to you, which is in progress, we stratified the patient with a complex system of prognosis prediction based also on MTV at baseline. And we are confident that we could work it this way. But it's too early to. So in conclusion, if you have early favorable disease, and if you deliver standard ABVD, you should remember that you are going to lose some effectiveness of treatment if you give up with the radiotherapy. In early unfavorable Hodgkin lymphoma, you could omit radiotherapy if you deliver something more active compared to standard ABVD.
Thank you. Thank you. Very clear. Thank you very much.
Thank you. Any other colleague would like to ask something? There's one question put up in the question box. If a PET is fused with the plain CT scan, what are the features by which you can indicate that there is malignancy?
Sorry, but I don't understand well the question. So, in other words, PET-CT is not used to make a malignancy diagnosis. It cannot take over the classic biopsy, so you are not allowed to do that. But of course, you can get a large number of other information besides the histologic diagnosis. Yes.
Dr. Gopinathan, your question.
Sir, good evening, sir. Thanks for such an informative talk.
Thank you.
Yeah, sir, sometimes in Hodgkin's lymphoma, stage 4 disease at baseline, when multiple groups of lymph nodes are involved, at the end of treatment PET-CT, that is after a good interim resolution, then after when we de-escalate, when we do an end of treatment PET-CT, some of the lymph node groups have a borderline SUV activity, like somewhere around 2.8 to 3. But we find that the node is subcentimetric. In these kind of borderline cases, how do we go about deciding further therapy, sir?
Well, thank you very much for the question, which, to tell you the truth, was addressed by a study specifically devoted to score 4 patients with a single node at the end of treatment. Was a study performed by a team in Naples, in Italy, in which patients underwent a systematic biopsy on the patient scored 4 in a single node after radiotherapy. And in most of those patients, no harbinger at all of Hodgkin lymphoma was found. Just to stress that when you have a single FDG with somehow faint FDG uptake with SUV max of 3, I remember that SUV of the liver is between 2 and 5. So this means score 3 or score 4, even if you end up with a score 4, you should always think to false positive results, especially if the site's residual node was located in a site where a large nodal mass was detected at baseline.
Right. Thank you, sir.
Thank you. Dr. Dharma. You have a question, Dr. Dharma?
Yeah. So the question is that lymphoma involving only marrow, and the first time diagnosis is always made by the bone marrow biopsy, and the PET scan then shows the increased activity. So do you follow with the PET scan, or you in these kind of patient you'll do the marrow and then?
Sorry, Dr. Kudari. What kind of histologic subtype of
we do see sometimes the Hodgkin involving only marrow, or the B-cell lymphoma involving only marrow. In these kind of situation, the PET scan is like PET is uptake, and will you monitor with PET scan or just doing a marrow examination at the end of the treatment?
As far as, to tell you the truth, as far as only bone marrow Hodgkin lymphoma experience, I have no direct experience, and I haven't read anything in the literature except for HIV positive Hodgkin lymphoma, in which pure bone marrow Hodgkin lymphoma could exist, but I have no experience. On the other hand, diffuse large B-cell lymphoma in the bone marrow only is rather common, and the number of focal lesions present could give you an important insight of the outcome of the treatment, because you know that if the lymphoma is multifocal, the treatment outcome is much worse than if the lymphoma is unifocal. So my suggestion is to follow up the patient with PET-CT if the lymphoma is multiostotic. I don't know how to say, is multifocal.
Thank you.
Dr. Shekhar?
Yes. Hello. Sir, you are just mentioning that in follicular lymphoma, based on the PET report, if the PET SU value is after a certain level or 10 or 12, it is an indication for going for treatment. It indicates a higher grade. Many times we see a combination. You get a follicular lymphoma grade 1, grade 2, but the PET showing in one area around 20, 25, another area it is showing only about 8, 10. In such a situation, how to take a decision whether to go for treatment based on the PET, or should we base our own clinical basis?
Thank you very much for the very interesting and also puzzling problem which occurs normally in the clinical practice. So this points toward the multiclonality of follicular lymphoma and the popping up of new clones we could emerge during non-follicular lymphoma biology. So I suggest to be pessimistic. How do you say, to not overlook the high grade component of follicular lymphoma? You arose a very, very important question, which could explain the suboptimal treatment in some case of follicular lymphoma. So, of course, you can adjust your decision based on SUV max. If you have a SUV max, for instance, higher than 15, I strongly suggest to you to biopsy this site. Other policy could be address the patient to a strict follow-up with a second PET-CT in 4-5 months, for instance, and you could get some information about the evolution of this high avidity of focus. but please consider the worst outcome always.
Thank you. Thank you very much.
Thank you. Mukul?
Sir, my question is pretty basic one. In this regard, are we left with any low-grade lymphomas which are not to be followed up with PET scan?
Sorry, I didn't catch.
Are we left with any low-grade lymphoma which are not to be followed up with PET scan? And secondly, what about follicular lymphoma with the peripheral spill, with blood involvement, basically?
With peripheral?
With peripheral spill.
So first question is, if there are low-grade lymphomas, are there some of them which are not to be followed up with a PET scan?
Yes, absolutely. So in most, a number of low-grade follicular lymphoma have an underlying clonal marker which could be detected in bone marrow, for instance, by bone marrow aspirate and the gene rearrangement. So this is much more sensitive than PET-CT in general. But this is a very important question because thank you very much for the question, because we have an experience on both PET-CT and molecular biology in follicular lymphoma. And we observed some patients having a complete negative PET scan with residual disease on molecular biology. And on the other hand, patients with a negative PET scan and a positive molecular biology. So we think that those two different techniques assess residual disease in a different way. If you ask me if the prognosis was worse in patient having residual disease on molecular biology or on PET-CT, I'm not able to answer. I would say that it's more frequent to have a residual disease on PET than on molecular biology, but the outcome is worse in both cases. So if your question was addressed to follicular lymphoma, probably other is very difficult to claim something.
Other lymphomas is difficult. And what happens with if the peripheral lymphoma has a blood involvement, if there are follicular cells in the blood?
I could answer indirectly with our experience in chronic lymphocytic leukemia, in which PET-CT has a definite role in predicting disease transformation or aggressiveness in case of residual mass, FDG-AVID, or in other words, the transformation in Richter syndrome. But we do not have any data on the real meaning of cell spillover in the peripheral blood and its relationship with PET-CT. I don't know. I am not able to answer. But the utility of FDG PET-CT is even in case of leukemization of a lymphoma, is useful when residual masses are shown. Otherwise, it is not useful to portray what happens in peripheral blood. Was it? Did they explain what?
Yes. Thank you.
Okay, so we have some question from the audience. After 4 cycles of R-CHOP, the PET scan shows Deauville score 4, and the lymph node is in an area which cannot be biopsied. What will you do?
Well, there are studies showing that the predictive value of interim PET-CT increases along with treatment duration. In other words, there are French studies showing the predictive value of PET after 2, after 4, and at the end of therapy. And PET after 4 cycles was a little bit more predictive on what happens after 2. Someone could infer that this is predictable. As you go closer to the end of therapy, of course, the PET increases its predictive value. But another observation is that false positive results are much more frequent, very close to the treatment start for large mass shrinkage, which is a case of false positive results. But after 4 cycles, I am not confident that this could be a false positive result. So as the time goes by and the number of cycles increases, the specificity of a positive PET scan increases. So I do not think that we should overlook the meaning of a positive PET long way after treatment start. Not long way, but midway after the treatment start. Sorry.
So I have a question. If you take the end of the treatment PET scan and you get an area where the Deauville score is 3 or 4 by 2 different PET specialists, and the lymph node is inaccessible, what do you do?
Sorry. Okay. Yeah. In which cases you mean in Hodgkin?
Hodgkin.
And sorry, Dr. Agarwal, but I should ask you, was there a large nodal mass at the beginning?
Yes, there was.
There was.
There was.
I think you should strongly suspect a false positive. Second question, sorry. Are there other positive nodes, or
No.
you mean about single node?
Single.
Single mass, single node, okay. I strongly suspect a false positive results. We had some experience, sorry for tell you something which is not completely scientific, but we had an experience on dual point PET scanning with a PET-CT performed at 60 and 120 minutes after FDG injection. And we were able to observe a declining value in patients presenting with a residual uptake, which never heralded an impending relapse. But this was not absolute, Dr. Agar, because there are some cases of Hodgkin lymphoma in which, especially in mediastinal, in which granulomatose reaction account for false positive results. So your caution should be increased if you do see that in the mediastinum, not because of the thymus, which easily distinguishable by an adult mass, but for some, I don't know how to say it more precisely, some granulomatose reaction of the host against the tumor. I suggest that a second scan should be done after 2 months from the previous one.
Right. And do you always recommend a biopsy if there is a Deauville 4 end of treatment?
Yes, as I mentioned before, usually not. There are studies showing that in case of a single spot of FDG uptake, this could be a false positive results. But there is plenty of cases also of diagnosis of resistant disease starting with a single node with a residual FDG uptake, as I showed you in the case report I presented in my presentation. So forgive me for this double face answer, but really there are cases in which you should judge case by case.
Your experience is phenomenal and you shared it with us. We enjoyed and we learned a lot. one statement you made that between bone and marrow, you cannot differentiate, right?
Right, perfect. Yes, thank you very much for the question. Yes, this is due to of course, it depends from the histological subtype you are dealing with, but the PET-CT has not a detection power, even if combined with CT, to show whether the persisting FDG activity belongs to bone marrow or bone. So that's why we usually we adopt the usual terminology bone marrow. This depends on our lack of discriminancy between those two situations.
Are there any more questions for sir? We have 1 or 2 minutes. So there appear to be no more questions. In that case, Dr. Galamini, thank you very much for being with us.
No, it was a pleasure for me.
Great session. Enjoyed it and learned a lot.
Thank you very much, Doctor.
Thank you.
Thank you very much. See you.
Have a wonderful evening. Okay, bye-bye. Okay, so we will move on. We have our second speaker who is already logged in. We have Professor Andrew Davis from UK, and it's a pleasure to introduce him. He is Professor of Hematological Oncology in the Cancer Sciences Unit in the Faculty of Medicine, University Hospital, Southampton. He completed his training in medical oncology at St. Bartholomew Hospital in London, and as a Cancer Research UK Clinical Fellow, he undertook a PhD examining the molecular mechanisms underlying transformation of follicular lymphoma to a more aggressive histological subtypes. He specializes in the treatment of malignant lymphoma and the use of high-dose chemotherapy. He has a particular interest in the investigation of monoclonal antibody-containing therapies applied to lymphoma and in the translation of biomarkers and novel therapies to the clinical arena. He has extensive experience in early phase trials, including leading several first-in-man lymphoma studies. He is the past chair of the UK National Cancer Research Institute High-Grade Lymphoma Study Group, Director of Cancer Research UK National Institute of Health Southampton Experimental Cancer Medicine Centre. He is also the Wessex Regional Lead for Cancers in Teenagers and Young Adults. He's going to speak to us today on managing newly diagnosed DLBCL. Do we do something different in 2022? Over to you, sir.
Great. Thank you very much for that really kind and warm invitation. It's great to be with you today. My apologies. I haven't got my tie on. I'm in clinic at the moment and we've had ties banned since COVID. So I'm sorry, I'm looking a little bit scruffy. But anyway, let me just find my share screen and I hope that you can all see that. And I hope that we can share what I can see. So just bear with me 1 minute while I get that ready. I hope that you can see a full screen now. Yeah?
Yes, sir.
Fantastic. So it's great to be here with you. I've been asked the question is, managing diffuse large B-cell lymphoma in 2022 is, do we need to do something for the newly diagnosed patient? Do we need to be changing the way we approach the management of these patients? And I think this is a really important and exciting question. So I'm going to say a little bit, but perhaps not completely at the moment. And I'd like to present some of the sort of data kind of supporting that statement. Just before we begin, I'd like to just say that I've got a number of conflicts of interests that I'd just like to declare to the audience because of my interactions in terms of clinical trials. So our expectation in diffuse large B-cell lymphoma of success is high. From clinical trials, we expect about 80% of our patients to be alive 2 to 3 years after diagnosis. Now, Of course, we recognize that the real world situation is different to that, and that's for very many reasons. But of course, the patients that tend to go in clinical trials have got a better performance status. They tend to lack comorbidities, and they tend to be younger and don't have those kind of the issues of frailty. So if you take a kind of population-based analysis of diffuse large B-cell lymphoma, we reckon that about 60% of patients are alive 2 to 3 years post-diagnosis. And what that means is that 40% of our patients are being failed by our kind of conventional approaches. So there's lots of work to be done in diffuse large B-cell lymphoma. Now, we're quite good at identifying which patients we think are going to do well, and I think which patients are going to do less well. And I'm still very much wedded to the calculation of the International Prognostic Index, which has really weathered the test of time over these years. It's very simple to calculate, and then we recognize that those patients who lack risk factors, maybe have 0 or 1 IPI points, have an excellent outcome, as shown by the top blue line, whilst those patients who have multiple high-risk variables described in the IPI, their prognosis is much less good, and we expect their overall survival to be somewhere in the order of about 50% at 2 to 3 years. Now, we can couple those clinical variables with some information that we have about the biological prognosis. So the cell of origin model in terms of phenotype, GCB or ABC, and we've seen from retrospective analysis that the ABC groups have a less good prognosis. And then we can layer on that information about the expression of MYC and BCL2, or the presence or absence of translocations involving MYC and BCL2 and BCL6, of which we can add to more about that in the discussion a little bit later. So we're layering up information about clinical risk, and that helps us inform the patient and perhaps helps us inform our approach to therapy. Now, just in terms of talking about prognosis, I really like the NCCN IPI, and I get my fellows to calculate the NCCN IPI. I know it's a little bit more difficult than doing the IPI because, of course, it uses sort of semi-continuous variables, and there's a few more things to think about. But actually, the NCCN IPI is really good because it gives a wider split in terms of overall survival prognosis for the different groups. And we recognize that those patients who have a low risk NCCN have a really very favorable outcome. So it's really good at identifying those very good risk patients. But even if you look side by side, IPI, the revised IPI, and the NCCN IPI, in the red line for the high risk groups, none of those are really identifying a group of patients whose overall survival is less than about 50%. So we need to do better. And I think that we are seeing now more models that are incorporating a broader range of prognostic variables. And we've seen this from the Petrea consortium, the inclusion of radiomics data from a PET scan that helps guide the IPI and provides us with a much clearer prognostic scoring system than the IPI alone, and that's the MIPPI, or I can't say it right now. So the IMPI. And that includes total metabolic tumor volume as well as the components of the IPI. And I think we're really quite excited about this prognostic score because there's very clear discrimination in the different groups. And I think we've got to the point now that calculation of metabolic tumor volume by PET, as you would have heard earlier, is becoming much more standardized, and it's much more realistic to be able to do that within our own individual departments. And as a result of this really nice scoring system, we are able to generate individualized risk for patients. So this is just an example from the Petrea consortium of this patient who presents with a high tumor volume, and we're able to add information about the patient's risk variables into an online tool that can give an individualized prognosis for the patient. And I think that's really important because, when we think about these kind of things, that's what we need to be providing our patients, and that's probably going to be the only way we get to improving our our outcomes in the highest risk patients. So for example, this patient has a metabolic tumor volume of over 4 liters. They're age 61, they have stage 4 disease, and that gives them a progression-free survival at 3-year probability of just 30%. Now, another example of this is where a patient who has a much smaller tumor volume, just almost 300 mils of tumor volume, who's younger, has stage 2 disease, and our expectation of being progression-free at 3 years is 84%. So I think what we're moving towards is a better a way of looking at risk and providing personalized risk that can help inform the conversations we have with our patients in DLBCL. So, and we also know that the metabolic tumor volume gives us value in terms of weighting of the biomarkers of cell of origin. For example, this data from the Goya study shows that we can very nicely split GCBs and non-GCBs into high and low total metabolic tumor volume, and that gives additional prognostic information. So we're building up a case in terms of provision of prognostic information for us and for our patients, which I think is going to become increasingly relevant in the not so distant future. So let's first of all focus on what should we be doing in terms of early stage diffuse large B-cell lymphoma in 2022. Now, of course, we've all grown up on the notion of giving abbreviated chemotherapy followed by radiotherapy, and the acceptance from the SWOG studies that was non-inferior to giving complete courses of CHOP chemotherapy. The data from the German FLIER study, published now 2 years ago, showed that those patients who didn't have bulk and who didn't have IPI risk factors, so those patients who were younger than the age of 60, in the non-inferiority FLIER study, progression-free survival and overall survival was non-inferior in those patients receiving 4 cycles of R-CHOP chemotherapy compared with those patients receiving 6 cycles of R-CHOP chemotherapy. So actually reducing the number of cycles we give patients is not associated with any adverse outcomes in this group of patients who are at the lowest risk. We see 3-year progression-free survival in these patient populations of about 96%. So really excellent outcomes. Now, is that lesson from the FLIER study relevant for those patients who are older? Is it relevant for those patients who have adverse, maybe one or more adverse prognostic features? We're not entirely sure. I think most of us feel comfortable with extrapolating this data into the older patient population, but we feel much less comfortable when there may be any adverse risk features. Now, not only are you abbreviating therapy by giving 4 cycles of R-CHOP chemotherapy, but also you're reducing toxicity, both hematological and non-hematological toxicity, by about 1/3. So for patients who don't have risk factors, 4 cycles of R-CHOP in early stage disease, doesn't matter whether it's extranodal, except testicular or not, this is a good approach. The other approach that increasingly has become part of our view on early stage diffuse large B-cell lymphoma is the use of risk-adapted approaches according to the PET scan. And we saw presented at the International Lymphoma meeting 2 years ago, now it will be, the data from the LNH091B study from the LISA group, which asked the questions, can an interim PET scan in limited stage disease help us determine exactly how much therapy that we want? And so this was again a group of low risk patients, IPI 0 points, but did include up to the age of 80, so kind of an exception really to the rules. And they asked the question, shall we give in the top line conventional 6 cycles of R-CHOP chemotherapy, and on the journey they accumulated information by doing a PET scan after 2 and 4 cycles, or shall we take a risk adapted approach? And they gave 2 cycles of R-CHOP chemotherapy given on a 21-day cycle. If the PET scan was negative, then they went on to have just 2 more and completed therapy with a final evaluation at PET 4. So really for those patients who were PET negative, the experimental approach was simply to give 4 cycles of R-CHOP chemotherapy. For those patients who had an interim PET scan that was positive, Then they continued with R-CHOP, and if the PET scan after 4 cycles was still positive, they came off study for alternative therapy. But if it was negative, they went on and had a total of 6 cycles of R-CHOP chemotherapy. The primary endpoint was non-inferiority in terms of progression-free survival. The PET review was central, which was, of course, relevant. And of course, you can see in this strategy and the strategy that I described for Flyer that radiotherapy was not involved. And the outcomes of these studies, there we go, sorry, I'll just demonstrate what there is, that there was no difference in outcome. Excellent outcomes in the standard arm, progression-free survival, 90%, in the experimental arm, progression-free survival at 3 years, 92%. So really good outcomes. And I think a PET-directed therapy in limited stage disease, trying to give 4 cycles of R-CHOP chemotherapy, to me is the new standard of care for diffuse large B-cell lymphoma in limited stage disease. Now, I do recognize that it does generate somewhat of a minefield in terms of our approaches. Some people who, including the SWOG study, who've looked at interim PET scans have done it after 3 cycles rather than after 2 cycles. But now we've kind of got a panoply of treatment choices that we need to individualize for our patients with limited stage disease. Of course, for those patients where you worry about poor tolerability of systemic therapy, then 3 cycles of R-CHOP chemotherapy followed by radiotherapy, if you're looking at a low morbid site, is entirely appropriate. For those patients who have 0 IPI points, then one can consider 4 cycles of R-CHOP chemotherapy with no interim PET scan. If you wanted to take a PET adapted approach, you could give 2 to 3 cycles of R-CHOP chemotherapy, look for a negative PET scan, give 1 more cycle to a total of 4 if they're PET negative, or if they are PET positive, continue to give 6 cycles of R-CHOP with radiotherapy. So it's not entirely clear as to what your optimal strategy should be. But what I will say is that this is an individualized choice based upon the patient's age, risk factors, comorbidity, their ability to tolerate systemic therapy, and the potential toxicity that there may come from radiotherapy. But what's really good is that we've been able to drive in 2022 to a reduction in the amount of therapy that we offer patients with limited stage disease, and as a result have had no fall off in the efficacy of our approaches. Now, what about in advanced stage disease? Well, over the last few decades, we've done a huge amount of work and recruited tens of thousands of patients into clinical trials to improve upon the outcome of R-CHOP chemotherapy. And despite very many studies, really, we haven't seen much that has altered our practice. We've tried to abbreviate the interval between chemotherapy by giving R-CHOP 14. We have tried to introduce new drugs to improve outcome. We've tried to build upon the response of R-CHOP chemotherapy by consolidating with high-dose chemotherapy and stem cell rescue. We've tried maintenance strategies, and of course we've tried to modify therapy according to the model of a cell of origin. We use different anti-CD20 monoclonal antibodies, and we've tried to look at giving chemotherapy in a more intensive way with infusional schedules. And really we've kind of failed to have a significant impact upon outcomes. One could argue perhaps that the outcomes with R-ABCVP may be better than R-CHOP. However, in patients with IPI risk points, however, those regimens are very difficult to give. They've got high toxicity. And actually in the randomized study, the R-CHOP arm didn't perform very well. And the jury is out on the data from the Polarix study, which I'm going to come to a little bit later. So, of course, what we tried to do is we tried to capitalize upon the biological information that we had gained about diffuse large B-cell lymphoma. And in the simplest form, we had tried to divide diffuse large B-cell lymphoma into 2 distinct phenotypes based upon the transcriptional profile of these patients. And of course, we're familiar now with classifying diffuse large B-cell lymphoma into either the GCB-like DLBCL or the ABC type, those that look like activated B cells in the peripheral blood. And we recognize this is based upon a transcriptome model, but one can use a model of surrogacy using immunohistochemical markers. And in retrospect, the ABC looks like they do less well. So much of our focus has been over the last probably 8 to 10 years or so now, was to try and improve the outcome of those patients with the ABC group. And we recognize that the ABC group were uniquely driven by a range of recurring mutations that resulted in overactivation of the NF-kappa B pathway. And so as a result, there's been a number of studies that have tried to add various modulating therapies to R-CHOP chemotherapy to try and improve outcomes. So the results of these will be familiar to you. The addition of lenalidomide, which we think as a single agent drug is quite useful in ABC DLBCL, had no improvement in outcome when added to R-CHOP chemotherapy in a big randomized study, the robust study, when restricted to ABC type DLBCL alone. Now, in a randomized phase 2 study, there was a suggestion that it probably did improve outcome, but actually the designs of the study are quite different. The randomized phase 2 study is really very underpowered. And actually, when we look at the big phase 3 study that recruited almost 600 patients, we know that there was no difference in outcome. But many people are still very interested in thinking about the role of lenalidomide in frontline DLBCL. And I'm going to come back a little bit to that. But at the moment, in non-GC DLBCL, there's no convincing evidence to suggest that that's something that we should be doing for our patients. We've also looked at the addition of ibrutinib to R-CHOP chemotherapy in the very important Phoenix study. Again, took patients with non-GC, so ABC type DLBCL, and we randomized those patients between having R-CHOP with ibrutinib or R-CHOP with a placebo. And again, this very large study of 800 patients, the primary endpoint was event-free survival. And you can see that there was no difference in outcome between the two groups. However, when we looked at that data a little bit closer, we could see that there may be a potential subgroup of patients with DLBCL who do benefit from the addition of ibrutinib to R-CHOP chemotherapy. And those were the under 60s. And if you looked at patients who were under the age of 60, the addition of ibrutinib was associated with a 16% improvement in progression-free survival and also a significant improvement in overall survival. So there may well be something here to suggest that the addition of a BTK inhibitor to R-CHOP chemotherapy may improve the outcome for patients with non-GC DLBCL. For those patients who were older than the age of 60, there was a difference in outcome in that the ibrutinib arm was inferior. And that's because there was an increased rate of toxicity, potentially infective toxicity, in those patients who received ibrutinib. Now, ibrutinib has a lot of off-target effects beyond BTK. I'm going to come back to that again a little bit later. But there may be the reason why they did less well was because of the off-target ibrutinib effects, particularly affecting T cell function. So this kind of gives us a window on the fact that BTK inhibitors may be of some value in frontline diffuse large B-cell lymphoma, but their role is yet to be proven. And I'm going to come back to that a little bit later in my talk. So the question is, why did those studies not work out for us? You know, we had a good idea. We had drugs that potentially hit the target. Why didn't they improve the outcome of patients with frontline DLBCL? Well, it may well be that we selected the wrong patients. You know, we know in clinical trials, we select the best of the patients, those patients who have enough time to undergo screening investigations, those patients where there's enough time to send their sample off to a central laboratory, etc. And what we do recognize is that those patients who need a very short time from diagnosis to initiation of treatment have a much worse prognosis, reflecting the biology of their disease, compared with those patients where the process is much longer because of the kinetics and the pace of their disease is much slower. So we maybe chose the wrong patients. Maybe we didn't choose the right drugs and we weren't selective enough in terms of the targeting we used. Or maybe actually there's a lot more in terms of the biological heterogeneity of diffuse large B-cell lymphoma that we didn't understand at the time, and that has been confounding the success of trying to perform trials that are driven on the biology. And of course, what we know now, as a result of a number of studies that have been published within the last 3 or 4 years or so, is that actually the molecular landscape of diffuse large B-cell lymphoma is much more complicated than we had originally thought. And a simple model of trying to dichotomize into ABC and GCB is a massive oversimplification. And of course, within there's a range of different oncogenic aberrations that we should perhaps be targeting. So, I mean, probably the most broadly accepted model now, based upon the genomic classification, which looks at recurrent mutations, copy number variants, and structural variants, rather than a transcriptional program, is the LymphGen classification, which has come out of the NCI. And that really tries to divide diffuse large B-cell lymphoma into at least 7 distinct subgroups. And what it does do is it divides ABC and GCB into smaller groups that have common patterns of genomic aberration, and then potentially have a common pattern of targetable lesions that we can look for in future studies. Now, this is not prime time yet. It's not prime time because actually, despite the extensive nature of this classification, 40% of patients with diffuse large B-cell lymphoma do not fit in to any one of these 7 groups. It also takes time because you need to do a whole sort of exome or just an extensive mutational panel to be able to define these subgroups, as well as transcriptional analysis. So we can't really do that yet in a clinically relevant time frame. And then performing clinical trials on very small subgroups of this disease is going to be very challenging to come up with trials that are suitably powered to be able to use that data, you know, and to randomize patients. So I think there's a lot of work to be done until we're able to employ this complex model of heterogeneity in DLBCL. But I think this is where we're going to have to get to. But actually, at the moment, asking for a panel in DLBCL and frontline therapy probably isn't going to give you a lot of information to work with. But watch this space. Now, of course, we've seen this year 2 new classifications of lymphoma, or revisions of our previous classification. Now, this is difficult for the community, but essentially the message I want to give you is, in terms of DLBCL, not much has changed. Really, everything in DLBCL, unless it's one of those pre-specified particular types, such as primary CNS DLBCL, DLBCL of the testes, intravascular large cell lymphoma, primary mediastinal lymphoma, high-grade B-cell lymphoma, etc. Pretty much everything, our common and garden DLBCL, is still being lumped together in the not otherwise specified category. And that represents all nodal and extranodal diffuse large B-cell lymphomas, which aren't in one of those highly specialized distinct categories. Now, in the previous classification, we've talked about various morphological variants. We've talked about biomarker-driven subtypes such as CD5 positive, those who overexpress MYC and BCL2. But actually, in the new classifications, those have been significantly de-emphasized, because actually it's turned out that those are a quite weak prognostic impact. The classifications have maintained the cell of origin for the moment, for better or worse, although it's not influencing our clinical practice, but it does give us a framework for describing the biology of the disease. And at the moment, the use of the molecular genetic classification, such as the LymphGen classification, is expected, and we expect to transition to wanting to be able to use these, but at the moment, they're not ready. And I think this quote from one of the papers says, look, there's no unifying concept for the proposed clusters, and the significance of these drivers has not been established so far. So until we get to the point of having a unified genetic framework for diffuse large B-cell lymphoma, NOS, don't necessarily need to use these. So as I say, you don't need to worry about trying to request mutational panels or whole exomes on these patients. When we looked at this classification, there was a lot of agony about whether we should group those extranodal lymphomas that were of an ABC subtype together, because we recognize that in primary CNS lymphoma and primary testicular lymphoma and leg type DLBCL, that they are of the ABC phenotype, that there is a high frequency of mutations in MYD88 and CD79, and they tend to occur in immune privileged sites. So there was a kind of a drive to call these groups of tumors extranodal ABC type DLBCLs of immune privileged sites. Now, a lot of argument, that's something that maybe the classification will go towards in the future, but at the moment it's kind of still being considered, but it's a framework for thinking about those groups of patients. And there were some changes to the way we look at double hit and triple hit lymphoma, which I'll come back to a little bit later in the talk. So really, in terms of 2022, how do I need to think about DLBCL? Well, in terms of pathology, probably don't think about it too much differently to what you're doing. Both the majority of it falls under the NOS classification, and that you should maintain the use of the cell of origin description if you're doing so. Okay, so we are very lucky in DLBCL that we have a whole panoply of novel therapeutics that are in the sort of early stages of clinical development or have now reached the clinic. And this is a really exciting time to be involved in therapeutic development in this group of diseases. Now, of course, we have a whole range of drugs that affect pathways that are dysregulated in diffuse large B-cell lymphoma. We have drugs that may affect the microenvironment which the DLBCL exists. And of course, we have a whole range of new drugs that antibodies that target cell surface markers, and they may be naked antibodies, they may be antibody drug conjugates, and of course the bispecifics. Now, how can we use those in 2022 in our frontline therapeutics? Now, of course, there's been a lot of talk about polatuzumab, and just briefly to refresh your memory, polatuzumab is an antibody drug conjugate which targets a component of the B-cell receptor CD79B. The cytotoxic payload that the antibody takes with it is MMAE, or monomethyl auroristatin E, which is the same cytotoxic payload as is carried by brentuximab vedotin, which we use in anaplastic large cell lymphoma and also in Hodgkin's lymphoma. And the payload is linked to the antibody by a cathepsin B sensitive linker. You'll be all very familiar with the use of antibody drug conjugates, but briefly, the antibody drug conjugate binds to CD79B, a component of the B-cell receptor. It results in internalization of the complex, and within the acid environment of the lysosome, there is cleavage of the linker and release of the cytotoxic into the cell. MMAE is a highly potent microtubular inhibitor which causes disruption of the microtubule and apoptotic catastrophe and death. Polatuzumab on its own or in combination with rituximab is very useful, but actually the CR rates in diffuse large B-cell lymphoma are not particularly impressive. And of course, we know that achieving a high CR rate in DLBCL is a real prerequisite for long-term benefit. Now, we've seen this data in relapse and refractory DLBCL, where the addition of polatuzumab to bendamustine and rituximab is associated with a significant improvement in complete response rates to 40% and a significant prolongation in progression-free survival. So it was only natural to want to push out the boundaries of using polatuzumab into other clinical settings. For example, in the UK, and in collaboration with our colleagues in Germany and Austria and Spain, we're doing a huge study looking at the addition of polatuzumab to RICE chemotherapy to improve the outcomes in patients with transplant-eligible diffuse large B-cell lymphoma. But of course, you know, the holy grail really was to be looking at polatuzumab in the front-line setting. So the natural flow of events was to perform a study looking at polatuzumab with R-CHOP chemotherapy, and in the phase 1, phase 2, really had excellent outcomes. In fact, it's not R-CHOP chemotherapy, it's R-CHIP chemotherapy. It's because the vincristine being a microtubule inhibitor itself, is taken out to replace and replaced by polatuzumab. So that led to the randomized phase 3 trial that was reported in December at ASH and also in the New England Journal of Medicine, which is believed to be a significant step forward in the frontline therapeutic approach of diffuse large B-cell lymphoma. This was a large randomized phase 3 study in people with diffuse large B-cell lymphoma with IPI points 2 to 5, and they were randomized between R-CHOP chemotherapy for 6 cycles or to polatuzumab with R-CHIP chemotherapy. So very simple study design. There was additional cycles of rituximab given, and there are about 600 patients in each arm. The results of this study will be now familiar to you, and the addition of polatuzumab to R-CHIP chemotherapy was associated with a significant improvement in progression-free survival. And at 24 months, that improvement in progression-free survival was 6.5%. And if we think of absolute figures, at 2 years, we recognize that 70% of patients who had R-CHOP were progression-free, compared with 76.7% who had polar R-CHIP chemotherapy. So a significant improvement in the primary endpoint with a hazard ratio of 0.73. And that means a 27% reduction in progression or death through the addition of polatuzumab to R-CHOP chemotherapy. And there was no significant difference in safety. And in fact, there were less AEs in the polar R-CHIP group. So that's very interesting. Primary endpoint of the study was met. But is that clinically relevant? When we look at the overall survival, we see that there was no difference in overall survival between those patients who had polatuzumab and those patients who didn't have polatuzumab. And look, here we are with a drug that's supposed to improve 2-year progression-free survival, but it's not having a impact upon overall survival. And that may be related to the second and subsequent lines of therapies that patients may well have had. So, of course, when we have a phase 3 study that is associated with a positive outcome, then we want to look to see if there are any particular subgroups that may be particularly benefiting, especially when you're thinking about adding a particularly expensive new therapy into this mix. So a number of subgroups were assessed, and you can see just from looking very superficially at the forest plot that there is a great degree of clinical heterogeneity in the effectiveness of polatuzumab. So when we look to see which subgroups benefited, we see that those patients who were older, those patients who had an IPI score of 3 to 5, those patients with an ABC phenotype, and those patients without bulk were the ones that seemed to benefit. Now, of course, subgroup analysis in phase 3 trials is fraught with dangers. These are underpowered groups, even though these subgroup analyses may be pre-planned. And actually, the number of events in any particular subgroup may be relatively small. We might end up leaping to the wrong conclusions. So I feel quite strongly that we shouldn't be looking to use polatuzumab just in these particular subgroups. If you look, you can see, I don't know if you can see very clearly, if we look at gender, where you can see that there is a difference in effect to suggest that females benefit less than males, which, there's no biological reason why that necessarily should be the case. So I think subgroup analysis is difficult, and I wouldn't use this information to guide you in making a choice if you do adopt polatuzumab in your practice. Now, those patients who did progress after polatuzumab therapy had a less there's less use of second-line therapy in those patients receiving polatuzumab, which I think is very interesting. And of course, we recognize that the stakes are high for those patients who have relapsed DLBCL in terms of outcomes. So, the advantage, I guess, of using polatuzumab with no additional toxicity effect is that you may potentially reduce your need to offer patients second-line therapies. And when second-line therapies are difficult and toxic and expensive, that's a very good reason to potentially want to do it. Now, it has achieved a license and has been adopted in some territories. In the UK, for example, it's going through the NICE appraisal process, and we wait to see what the outcome of that will be. But I think you do need to recognize that you're providing a progression-free survival advantage, but no overall survival advantage, and it may not necessarily work for everybody. So, okay, let's explore the addition of new drugs to R-CHOP chemotherapy a little bit more in terms of molecular subgroups. Can we capitalize on this information about molecular heterogeneity? Well, some interesting retrospective analysis was performed from the Phoenix study that demonstrated that there were some groups of ABC type DLBCL that particularly benefited from the addition of ibrutinib to R-CHOP chemotherapy. And they were the MCD group, which is characterized by chronic active B-cell signaling and is very, very dependent upon the NF-kappa B pathway and BTK activation, and the N1 group, which is really dependent upon NF-kappa B, again, through a diverse range of signaling mechanisms. So it's really interesting to see really excellent outcomes in some of these patients. So it builds upon my idea about the benefit potentially in some subgroups of a BTK inhibitor. Now, acalabrutinib is a next generation BTK inhibitor with much greater kinase selectivity than ibrutinib. So some of the off-target effects that we see with BTK inhibitors are lost, and therefore perhaps some of the effects on antibody-dependent cytotoxicity, and perhaps some of the effects on T-cell function, and perhaps platelet function with acalabrutinib, and of course cardiovascular mortality seem to be much less than with ibrutinib. So we've explored the use of acalabrutinib in frontline DLBCL. In this window study shown over on the right-hand side of patients with DLBCL, in patients with DLBCL, we can see that given as a single agent prior to chemotherapy, that very many patients, regardless of their cell of origin, have a very good outcome to acalabrutinib. So the addition of acalabrutinib to R-CHOP chemotherapy has been investigated and found to be safe, not to be affected by age, and with really some very excellent outcomes. And as a result, there are 3 frontline studies in diffuse large B-cell lymphoma looking at the addition of acalabrutinib to R-CHOP chemotherapy. I'm currently leading a study in the UK of 600 patients comparing R-CHOP to R-CHOP with acalabrutinib. There's a commercial study ongoing, and the Swiss group are also looking at it stratified upon the genetic profile of their patients. So I think we're very interested in acalabrutinib. We also know that acalabrutinib crosses the blood-brain barrier and therefore may have an impact upon CNS lymphoma rates as well. So a lot of interest in BTK inhibitors, building upon the observations. If you can give a BTK inhibitor more safely, then potentially you might start to have an improved outcome in your DLBCL patients. Interestingly, we've seen this month the report of the SMART START study from Jason Weston and his colleagues at the MD Anderson. And this was looking in patients with non-GCB DLBCL at a completely non-chemotherapy approach. And these patients were given 2 months worth of rituximab, lenalidomide, and ibrutinib. And we found that very many of these patients had a really excellent response with over 85% of patients achieving a response after just 2 cycles of non-chemotherapy. And afterwards, they went on to have some chemotherapy consolidation in combination with the non-chemotherapy regimens. And this was associated with some really excellent outcomes, including some patients who declined chemotherapy and just had the non-chemotherapy approach on its own. So I think this is really important because, you know, we may well be that we can take a non-chemotherapy approach based upon the biology in frontline DLBCL in the future. I'm not advocating that we might do this now, but it opens the door for further exploration. And really what it's getting to is the fact that by exploiting our understanding of the biology of the disease, that we're going to be able to do this and forget the one-size-fits-all R-CHOP model for the future, and that we'll be able to stratify patients very much better. Now, we saw presented now two years ago, well, just over 18 months ago, at the Lugano meeting, the ability to try and look to see if we can modify outcomes by targeting individual subclasses of diffuse large B-cell lymphoma with different drugs according to the LymphGen classifier, in addition with R-CHOP chemotherapy, in the hope of trying to improve outcomes. This was a very small randomized phase 2 study. The classification of DLBCL was done very quickly using a mutational panel, and a range of different drugs were given according to the pattern of oncogenic aberration. And when this approach was compared to using conventional R-CHOP without additional drugs, the endpoint of both complete response rates in each distinct genetic subgroup and progression-free survival overall for all patients was increased. So as a proof of principle, we can see that we might be able to improve the outcome of our patients with DLBCL by targeting distinct genetic aberrations. And this is just going to take a bit of time to work through. So I will say here, we can say in 2022, for advanced stage disease, R-CHOP chemotherapy 6 cycles remains the standard of care, or R-CHIP plus POLA if you are in an environment where you're able to access this expensive drug that provides a PFS but not an overall survival advantage. But things are changing, and I really feel that we are on the advent of a major shift in the way we approach DLBCL frontline therapeutically. Now, there are some very interesting new drugs that are going through phase 3 evaluation in frontline DLBCL as well. Tafasitamab, which is a enhanced anti-CD19 naked antibody, which seems to have a great degree of effect in relapsed and refractory DLBCL when added to lenalidomide, is now being looked at in the frontline study. And this has been added to R-CHOP chemotherapy, and it's been compared with R-CHOP in the frontMIND study. This is a massive undertaking of 880 patients in a randomized way, comparing R-CHOP to rituximab, lenalidomide, tafasitamab, and CHOP in the attempt to improve outcomes with progression-free survival as the primary endpoint. Now, that's going to be quite something to sell in terms of the total expense of the package, but actually the study has been launched with a high degree of ambition. Now, of course, we can't have a discussion about lymphoma without talking about bispecific antibodies and the excitement around the CD3 by CD20 bispecifics. And of course, there are 4 in later stages of clinical development. And really what they do is CD3 by CD20 bispecifics bring together T cells and CD20 positive tumors. And when they are brought in close apposition and can form an immune synapse, there is induction of T cell mediated killing of the tumor cells. And they can do this without MHC mediated antibody presentation. And we've seen this year presentation of data in relapsed and refractory diffuse large B-cell lymphoma, which is highly promising. Epcoritamab, which is a subcutaneously delivered format and given until disease progression, is associated with a complete response rate in patients treated with 3 or more prior lines of therapy of 39%. There's not many single agents that can do that in DLBCL, and it seems to work regardless of your risk factors, including patients who've relapsed after CAR T-cell therapy. And for those patients who achieve a CR, then those responses are proven in the top green line to be highly durable. So these are very effective therapies. Another bispecific, which is an IV formulation and has a different structure, glofitamab, has a similar complete response rate of 39%, but this has been given with a fixed duration therapy and has similarly highly impressive durability of complete response rates. So the question is, where do we fit bispecifics into the frontline regimens? Well, bispecifics are successfully being given with R-CHOP chemotherapy, and they seem to work very well with high complete metabolic response rates. And we're going to see in the future randomized studies comparing R-CHOP with R-CHOP with bispecific antibodies, which I think are going to be very exciting. We've also seen the use of bispecifics as a standalone therapy in patients with high-risk disease. Mosunetuzumab, which is another bispecific antibody, again targeting CD20 and CD3 in older patients who are not fit for R-CHOP chemotherapy, are associated with a high response rate and durability, and are all given with little in the way of side effects. There are risks of cytokine release syndrome, there's a risk of neutropenia and some other side effects, but generally really well tolerated with an overall response rate with just a bispecific alone of 63%. So I think, what we're trying to do is we're moving away from the, we've got to give everybody R-CHOP chemotherapy. So I think these are very exciting times. And of course, we need to think about how we might incorporate the cellular therapies and CAR T-cell therapies into our frontline approach in DLBCL in the future. We have recognized 3 approved CAR T-cells targeting CD19. There's variability in their approvals across different territories, but we recognize from the long-term follow-up data that in patients who have third-line plus DLBCL, these are associated with highly durable response rates, some really very, very impressive response rates. And in fact, for people treated at third line plus, 43% are now alive and event-free 5 years after reinfusion of their CAR T cells. So this is a regimen that's highly effective for patients with relapse disease. So there's a real push to try and move those up through the therapeutic lines. Now, I talked a little bit at the beginning of my presentation about how we might be thinking about risk adapting our therapy based upon some of those risk factors that we talked about at the beginning. And of course, there's a lot of interest in the interim PET scan, how the interim PET scan changes. We recognize that the interim PET scan is prognostic after 2 to 4 cycles of R-CHOP chemotherapy. There are still many patients who have a positive interim PET scan that do well, but we have been a bit reluctant to change therapies according to the interim PET scan, because perhaps we may not be able to modify outcomes with conventional chemotherapy. The best example of that is the PETAL study conducted in Germany with 600 patients. They gave everybody 2 cycles of R-CHOP chemotherapy and did an interim PET scan. For those patients who had a positive interim PET scan, they were randomized to either continue with R-CHOP chemotherapy or to have a more aggressive chemotherapy regimen that one might use in acute lymphoblastic leukemias. And actually, there was no difference in the outcome. So although you could identify a group of patients who had a poor outcome, giving additional chemotherapy couldn't change the phenotype. The LISA French GAIN study did a very similar thing, and for those patients who were interim PET scan positive, they offered them further induction therapy with high-dose chemotherapy and stem cell rescue. Now, this wasn't randomized, but it looked as if it could improve the outcomes of those patients. But I think the essential view is that giving more chemotherapy in PET positive patients is probably not a smart idea, and perhaps we should employ some of our modern therapies to try and improve the outcome for those patients. So for this reason, very many centers don't do interim PET scans, because up until now, we really haven't been able to do anything to change the phenotype of these disorders. The Zuma 12 study, albeit very small, conducted in 1 or 2 US centers, took patients who had high risk disease at baseline by virtue of having double or triple hit disease and then, or high IPIs, they did an interim PET scan after 2 cycles of anthracycline-based chemotherapy. And for those patients who were PET positive, they went on to receive CAR T-cell therapy. So you're putting out your highest risk group of patients and trying to do that early. And that was associated with a very impressive overall response rate and very impressive progression-free and overall survival curves, perhaps much better than one would have expected for this group of patients, where we would expect the outcome of overall survival at 2 years to be just 50%. So this may be our approach for the future, is to try and work hard to identify our patients at high risk at baseline, try and pull out those patients where things are going less well, and then to offer those patients therapies that are distinct from chemotherapy. And I think this is a really exciting approach. One of those ways of putting out patients who are doing less well is to use cell-free DNA and to look for dynamic changes in cell-free DNA as we go through our R-CHOP chemotherapy. There's a lot of work to be done in terms of standardization of this methodology and prospective validation, but we're seeing time and time again series demonstrating how useful this may well be. So that moves us towards a dynamic risk assessment in frontline DLBCL and potentially adaptive therapies. So we can take pre-treatment risk factor information. We can take basically clinical information, the IPI score. We can take information about the metabolic tumor volume. We can talk transcriptional information about cell of origin, and we can take genomic information about the LymphGen classification, pull that all together, give an individualized risk at baseline. Then we can track changes in cell-free DNA. We can track the interim PET scan, and we can pull out those patients where our definition of risk is high and potentially offer those patients who are doing less well interventions that are distinct, so the cellular therapies. So this is the way I see frontline DLBCL therapy changing. It may not be how it is now, but this is how I expect things to be changing. So in the last 2 minutes, I just wanted to say, what should we be doing about those patients with double and triple hit lymphoma? Because this is always a big question that I get asked. We have traditionally considered them to be a high risk group of patients with presenting in the 7th or so decade of life with high risk features such as high LDH, high stage, high risk for CNS disease. In our review of the classification of DLBCL, we think that probably the BCL6 translocations may not be as prognostically strong as those patients who harbor both MYC and BCL2 translocations, and there has been a move to push those out of this double and triple hit classification. We recognize also that those patients who have partners with non-immunoglobulin genes for their MYC rearrangements also appear to have a better prognosis than those patients who are partnered with an immunoglobulin gene. So not only is FISH important in your diagnosis in DLBCL, but actually trying to look at the immunoglobulin gene partners, because actually that may potentially be an important driver in terms of prognosis. So I think we all can agree that R-CHOP chemotherapy is an inadequate therapy for this group of patients. We recognize that the more intensive regimens may be associated with better complete response rates. And although we see intensive therapies may be associated with longer progression-free survival, our retrospective analysis suggests that perhaps they're not associated with better overall survival. I must admit, I am a great favor of using dose-adjusted EPOCH in patients with double and triple hit lymphoma, and that's based upon data from a prospective study, which is relatively small and single arm, demonstrated excellent outcomes in this group of patients. Now, I agree that the data for this is relatively limited and that there is data from data from registries and from the Flatiron database to suggest that there may not be an improvement in outcome using dose-adjusted EPOCH over R-CHOP chemotherapy. But actually, when you look at these registry databases, we see that the demographics of those patients receiving R-CHOP is very different from the demographics of those patients receiving dose-adjusted EPOCH. So I think the question about how you treat double hit and triple hit lymphoma, the jury is out. I remain comfortable with using the more intensified dose-adjusted EPOCH if patients can tolerate that and you have the logistics to be able to deliver this. So what does DLBCL look like in 2022? What's the outlook for DLBCL? Well, I think we can say that that multiple new modalities have been introduced into the DLBCL landscape. They've got a clear benefit in the relapse setting. It looks like they're going to have, many of these are going to have their benefit in the front line setting. But what we do need to do is optimize our approaches and optimize our sequences. And I think our improvements in DLBCL management in 2022 and beyond is only going to be coming from our better understanding of the biology of the disease. So I think what's really important is that we understand the biology and we get better at identifying those patients with DLBCL who are higher risk of disease progression so that we are allowed to intervene with new therapies before these patients progress. So thank you very much for listening. It's been really great to have your attention and I look forward to a really interesting discussion. Thanks very much.
Thank you so much, sir. That was wonderful. Great update, made the matter very clear. Failures, successes, optimism, and where we are going from here, everything was put together in these 45-50 minutes. Fantastic. Thank you so much for being with us. We do have a couple of minutes, so we'll take up one or two questions. Dr. Krishna Ratna.
Thank you for the excellent talk. Most of the questions have been answered. I have two questions. The first question is, what do you do for the patients who relapse within 1 year of diagnosis of DLBCL? Do you take them for salvage and auto or refer them for CAR T therapy?
So I think that's a really good question. I'll tell you what I do and tell you what I'd like to do. So we recognize that those patients who relapse within 1 year of completion of induction therapy have a very poor outcome. And we have been highly disappointed with the outcomes of high-dose therapy and stem cell rescue. Of course, at ASH and over the subsequent months, we've seen the publication of 3 randomized studies exactly in this patient population that have compared CAR T-cell therapy at relapse to high-dose attempts at reinduction and high-dose chemotherapy. 2 of those studies, one of which was a full report, one of those was an interim report, demonstrated an improved outcome with CAR T-cell therapy, and one of those demonstrated the CAR T-cell therapy was not anywhere, the outcomes were the same as with the high-dose chemotherapy. And there are very main differences in the design of the studies, which probably we don't have time to get into, and they're very great differences in terms of the use of bridging therapies and the times from apheresis to delivery of the cells, particularly in Europe. But actually, the 2 of those studies demonstrate a positive outcome in favor of event-free survival for the CAR T. Now, that has achieved licensing for Axicel in the second-line setting. It is not available in the UK at the moment, and that's because the funding has not been worked out, and it is about to go through the UK NICE process, which I'm sure you know is a pretty robust way of looking at cost effectiveness. So at the moment, I continue to offer these patients reinduction therapy, and if they have a response, consolidate that with high-dose chemotherapy, and have to reserve my use of CAR T-cell therapy for those patients who have failed reinduction therapy or relapse after an autograft. But I hope to be in the position, but recognizing the economic implication for us as a public health service, I hope to be able to do that in second line directly for those high-risk patients. Remember, your question is only about those very high-risk patients who relapse within 1 year, and the studies were only in those patients who relapse within 1 year. We continue for those patients who relapse after 12 months to offer those patients high-dose chemotherapy and stem cell rescue.
Thank you. The other question I have is, we have ibrutinib quite freely available generics. So if you have a patient with a high-risk ABC type of NHL, can we add ibrutinib because we don't have the luxury of most of the investigational drugs?
I think that's a really interesting question. I am a strong believer in the role of BTK inhibition in diffuse large B-cell lymphoma, but I am very conscious about the additional toxicity that that ibrutinib can bring in terms of the T-cell suppressive effect in when using R-CHOP chemotherapy. So the data in patients under the age of 60 in the Phoenix study demonstrated a very clear event-free and overall survival advantage. So I think you would have grounds for that in the younger patients. For those patients over the age of 60, which of course is going to be the majority of your patients with DLBCL, then it shouldn't be used because of the toxicity. So we are really keen to wait for the results of the cleaner BTK inhibitors in combination with R-CHOP chemotherapy. So certainly we don't have the luxury of generics in the UK. We're still BTK inhibitors still cost thousands of pounds a month. So it's not something that I could choose, but I think the data is very supportive in younger patients with non-GC DLBCL.
Thank you. Thank you so much.
Thank you, Dr. Davis. I think that's all what we could accommodate in the time that we had. I'm extremely grateful to you. What a lovely job you did and how much we have learned today. Thank you so much.
Thank you for inviting me. Enjoy the rest of your meeting.
Thank you, sir. Bye-bye. It's time for me to introduce our last speaker of the day. And again, we're extremely grateful to have Dr. Jonathan Cohen from the US with us this evening. To introduce him, he's MD, MS, Associate Professor and Co-Director, Lymphoma Program, Department of Hematology and Medical Oncology, Winship Cancer Institute, Emory University School of Medicine at Atlanta. He completed his clinical fellowship in hematology and oncology at the Ohio State University James Cancer Center prior to joining the faculty at Emory. His clinical focus is on the treatment of Hodgkin, non-Hodgkin lymphoma as well as CLL, where he manages both newly diagnosed patients as well as those who require stem cell transplant and treatment for relapsed diseases. His research focus includes the clinical investigation of lymphoma, where he aims to identify prognostic markers and designs clinical trials for novel agents for patients with relapsed disease. He leads national studies of new therapies and oversight of prognostic markers in lymphoma. He's also frequently asked to serve as a faculty member of workshops for new investigators. He earned his undergraduate degree at Emory University and received his medical degree at the University of Florida College of Medicine, where he earned his MD. He completed a residency in internal medicine and fellowship in hematology and medical oncology at the Ohio State University of Columbus, Ohio. During his fellowship, he also completed a master's degree in medical science, gathering additional training in the conduct of clinical and translational research. He'll be lecturing today on novel therapies in relapsed refractory aggressive lymphomas. Just to remind you that tomorrow is our day 3 and we begin at 6:25 p.m. Thank you. Over to you.
Great, thank you very much. Let me share my screen here. Can you see this okay?
Yes, perfect.
Okay, great, thanks. Thanks so much for the invitation. I hope the meeting is going well and everyone is having a good evening. I'm coming to you from Atlanta. It's about 11 o'clock in the morning on Monday morning, and hope everyone's week is off to a good start. So I actually will be talking about relapsed refractory diffuse large B-cell lymphoma, specifically identifying some of our novel agents and novel approaches, and actually very interesting. So I assure you this wasn't a planted question, but the last discussion segues very nicely into a large part of my talk today. So these are just my disclosures. So as we just heard, patients who have early relapsing or primary refractory diffuse large B-cell lymphoma have unfortunately had a very poor prognosis. And this is something that we see in our own clinics. It doesn't, you don't necessarily need a study to know that patients in this scenario have unfortunately had inferior survival. But these are two such projects which have highlighted this. So the first is a Kaplan-Meier curve from the CORAL study, which was initially designed to compare two different salvage regimens for patients with relapsed diffuse large B-cell lymphoma. And so RICE was compared to RDHAP. But in addition, one of the key findings from this trial is that those patients who had previously received rituximab, which was the majority of patients, and who relapsed within a year had a very poor event-free survival and a poor overall survival. And so this was published now 12 years ago, and so we've known for quite some time that this is a very high-risk group of patients. Many of them aren't always able to make it to autologous transplant, and even those that do, the minority of those patients will be cured. We also participated in a multi-center study led by Luciano Costa, who's at University of Alabama, Birmingham, looking at some of the specific predictors of poor outcomes for patients with relapse disease. And you can see here that the overall survival for patients, whether they have an early relapse, whether they have residual disease at the conclusion of therapy, or if they just have primary progressive disease, meaning that they progress while on initial therapy, is poor, with the majority of patients unfortunately passing away within 2 years. And so clearly we've known for a long time that there are better therapies needed for this class of patients, this group of patients. And so when I think about a patient with relapsed refractory large cell lymphoma, there are several factors that I take into consideration. So the first is the time to relapse. As I just mentioned, patients with early relapse are more likely to have more aggressive behaving disease, a poor response to second-line therapy, and unfortunately a shorter survival. In addition, though, to the time to relapse, there are a number of other factors that come into play. So one such factor is performance status or the presence of other comorbidities. Diffuse large B-cell lymphoma is a disease of patients in their 60s, usually, sometimes 70s. But I certainly have patients that are in their 80s and older. And depending on the comorbidities that may be present or their performance status, they may or may not be a good candidate for aggressive therapies at the time of their relapse. In addition, both patient wishes and family wishes, as well as other psychosocial issues, are really important. So I practice in Atlanta, which is a city of about 6 million people. But if you go 50 miles outside of Atlanta, to the rest of the state of Georgia, it's a very rural area. And many of those patients have difficulty with transportation into and out of the city. They may or may not have access to good healthcare resources locally. They may not want to spend their time in the car, sitting in traffic, going back and forth to our center. And so there's a number of reasons that patients may or may not choose to proceed with a more aggressive therapy. And these are all important things to think about when evaluating a patient and deciding which treatment to offer. And my last point, I think, is probably the most sobering, and that is that we do have what we think are curative options for patients with relapsed refractory diffuse large B-cell lymphoma. I have patients that have completed stem cell transplant that have been cured. I have some patients that have completed CAR T therapy that, at least so far, are still in remission. But unfortunately, the majority of patients that I see with relapse disease will not be cured of their disease. And I think it's really important to keep this in mind when counseling patients about which therapies to offer. So when I'm thinking about the different options, I think of three primary options for patients with relapsed refractory large cell lymphoma. One is autologous transplant, which has been the standard for 25 years now, almost 30 years. The second is CAR T, and then the third are sort of non-curative or palliative type approaches. And you can see here reasons that you may choose one over the other. So for autologous transplant, patients need to have disease control. So we know that if a patient goes into a stem cell transplant and does not have adequate control of their disease, that it's very unlikely that they will enjoy a long-term remission. They have to be able to go through stem cell mobilization and collection. They have to be able to tolerate high-dose chemotherapy, which is typically administered in the hospital. And so for those patients over the age of 70, this can be difficult. Not necessarily impossible, but you really want to have a patient who's in excellent shape and who's had excellent disease control. For CAR T, there are some aspects that are a little bit easier, so disease control is not required. It just requires 1 day of apheresis as opposed to a whole mobilization process. There's no need for the high dose therapy. So often patients that are not eligible for auto transplants can still be considered for CAR T. And as a result, you can administer this to patients of increased ages. And then for non-curative approaches, this is for patients who either choose not to proceed with definitive therapy or who are not eligible, but this may not require hospitalization, it may not require travel, it may result in better quality of life. And so it's important to recognize that not everybody is a great candidate to move forward with curative approach. Now, as we just heard, there were a couple of studies that recently came out that highlighted the fact that CAR T may improve outcomes for patients with early relapsing non-Hodgkin lymphoma. And this is one such study that was presented at the plenary session at ASH last year, the ZUMA-7 trial. And this randomized patients to receive either Axi-cel, which was the CAR T product, or to proceed to standard of care. And standard of care included at least 2 cycles of second-line therapy, with responders going on to stem cell transplantation and with non-responders coming off of protocol therapy. One key aspect of this disease that makes it different from some of the other currently available studies is that steroids were permitted, but that there otherwise was no bridging therapy allowed. So a patient had to be able to wait to be enrolled in the trial, randomized, and then go through the manufacturing process in order to be able to enroll in the trial and to receive Axi-cel. So this may have been a little bit of a different type of patient than the patient that may show up in the hospital who's very sick, who needs to start therapy right away. Nevertheless, we did see a significant improvement in event-free survival for patients who received Axi-cel as opposed to those who were randomized to the standard of care arm. You can see here that there is a large number of patients randomized to the standard of care who progressed within the first 2 to 3 months. And so these are people that likely didn't get to this transplant because they didn't have a good response to therapy or for some other reason. Whereas you can see with Axi-cel, 40 to 50% of patients enjoyed a long-term remission. Now, for those of you that may have reviewed this article already, you may be familiar with this consort diagram. And the reason that I want to bring this up is that if you look on the left side of the slide, you can see that there was 180 patients that were assigned to the Axi-cel group and 179 patients that were assigned to standard of care. So relatively equivalent. And you can see that most patients ended up either going through leukapheresis or received the first dose of salvage chemotherapy. So relatively similar. However, when you actually look at the right panel, you can see that only 64 patients that were randomized and started on salvage therapy ultimately received stem cell transplant. And this is because many of these patients had progressive disease at some point during the time between randomization and going on to transplant. So on the curves before where we saw all of those early events for the standard of care group, this is really where we see many of those events occur. What is a little bit less clear is for those patients that did respond to second-line therapy and went on to transplant, how did they actually do? And that is data that we don't have, at least from this trial. And so I think it's important to keep that in mind, that when you're deciding between one option versus the other, it's important to recognize that many patients didn't actually get to transplant. And amongst those that didn't go to transplant, many of them would have been candidates for CAR T anyway. Now, in addition to ZUMA-7, there was the Belinda trial, and this ended up actually being a negative trial. And there were some similarities and some differences between the studies that may have informed how it came out. So in both cases, patients had to be either early relapsing or have primary refractory disease. But one of the areas that's different with the Belinda trial is that all patients had to complete leukapheresis prior to randomization. And so these were patients that likely were maybe a little bit sicker because they could immediately go through leukapheresis and go on to randomization. They didn't have to be able to wait for randomization. In addition, bridging therapy was permitted in the CAR T arm. And so patients, again, didn't have to be so well that they could go without steroids, that these are patients that could receive chemotherapy. And you can see here the primary endpoint was event-free survival. This was defined as the time from randomization to stable disease or progressive disease at 12 weeks or later. And so the goal was to try to allow patients, even those that needed to go on to a second type of salvage therapy, to not necessarily be an immediate event. Now, when you look at the consort diagram for this, you can see that, again, there was a similar distribution during the randomization, 162 to CAR-T, 160 to standard of care. But if you look over here on the right side, you can see that, again, only 52 of those patients ultimately went on to receive autologous stem cell transplant, with an additional 10 receiving transplant after their second line of salvage therapy. So again, you can see that less than half of patients who were randomized to receive a stem cell transplant actually went on to receive the transplant. And again, I think it's important to keep that in mind when trying to look at the data. Now, interestingly, with this study, we saw that there was no significant difference between the standard of care arm and the CAR-T arm. And perhaps some of this is related to the fact that you don't see quite as many of those early drop-offs in the first 2 to 3 months because patients had to, it didn't count as an event until they were 12 weeks out. And so this is certainly interesting and looks very different than the curves from ZUMA-7. Now, also at ASH last year, we heard the results of the TRANSFORM trial, which compared lisocabtagene ciloleucel to autologous stem cell transplant. And this curve actually looks very similar to the ZUMA-7 curve. And so because of these findings, both Lysocell as well as Axicell have now been approved for second-line therapy in the United States, whereas tisagenlecleucel or Tisacel was not approved for second-line therapy. So these are just some of my general thoughts about this before we move on to some of the other topics for today's discussion. So patients with early relapsing disease and or primary refractory disease are at high risk for poor outcome. So even when we look at the ZUMA-7 curve or the TRANSFORM curve, we still see that the majority of patients will ultimately progress after CAR-T. And so we know that most patients are not being cured with this approach. And we also know that there's a whole lot of patients that don't even get to CAR-T and that weren't even part of these studies. And so I think it's important to recognize that this is still a significant problem. Having said that, CAR-T approach may be better than auto transplant, but it's important to consider the study design. So I consider this to really be a comparison of treatment strategies rather than the specific cellular therapy. I think if you really wanted to compare one approach, one therapy to the other, you would have to almost take patients that were already in remission, already in second remission, and then give some auto transplant and some CAR-T, because we know that patients we know that there were a lot of patients that came off that didn't get to auto transplant. And because of this, those patients who do achieve a response to therapy and go on to auto transplant may actually do okay. In the CORAL study, about 40% of patients with early relapsing disease who actually responded and went on to transplant achieved a long-term remission. And so this is a question that we don't fully have an answer to at this point. It is unclear, and I think probably unlikely, that there really is a significant difference in efficacy between the CAR-T products. There are some subtle differences in the way they're constructed. There are some differences in the way that they function, but overall, I think that the products are relatively similar. We've seen this with in the multiply relapse setting. I suspect that some of the differences that we saw between studies may have been related to study design, manufacturing timelines, and things like that, as opposed to an actual difference between the products. As I mentioned, manufacturing timelines and time to start the process are important. If I see a patient in clinic with aggressively behaving relapse disease, if I want to think about CAR-T for them, I need to be able to get them going pretty quickly and have their product available within a few weeks. And again, I think Dr. Davies actually mentioned this at the conclusion of his question and answer period. These studies do not address the role of CAR-T versus autologous transplant in patients with later relapsing disease. And at least in my own practice right now, for patients who have progressed in more than a year, outside of some special circumstances, I typically would look for auto transplant first in that case. But again, just to sum it up, we have not solved the problem of early relapsing diffuse large B-cell lymphoma, and there's a lot of work still to be done to try to better to achieve better outcomes for these patients. Now, in addition to the CAR-T therapies and auto transplant, there are a number of additional therapies for large cell lymphoma, which I would consider still to be novel agents, although fortunately several of these have now been available for a couple of years in the United States. So polatuzumab vedotin is an anti-79B targeting antibody drug conjugate. For those that are maybe not as familiar with this type of a construct, it includes a monoclonal antibody targeting CD79B, which is expressed in large cell lymphoma tumor cells. And then it is linked to a payload, to a chemotherapy payload, in this case, MMAE. This is the same payload that's used in brentuximab vedotin for relapsed Hodgkin lymphoma, as well as in T-cell lymphoma. And basically, I explained to my patients that it's like a smart bomb, and that it seeks out those cells that are expressing the target, and then it delivers the payload, which hopefully results in cell death. This this agent is currently approved in the United States in the relapse setting in combination with bendamustine rituximab, based on this randomized trial that was presented and published by Laurie Stennow several years ago, which identified an improvement in progression-free and overall survival for patients who received polatuzumab in addition to bendamustine rituximab for relapsed large cell lymphoma. Now, at least in the United States, we don't commonly use bendamustine rituximab as a standard second line or salvage regimen. We often will use gemcitabine-based approaches or platinum-containing approaches. However, I think it's clear from these curves that the polatuzumab certainly does add benefit compared to the chemotherapy alone. And for this reason, I have started to use this in patients that are either not eligible for aggressive therapy, or potentially, as is described in this study, that we're trying to bridge to a more definitive therapy. So if you give polatuzumab vedotin with bendamustine rituximab per the label, it's typically given for a maximal of 6 cycles. This agent is associated with peripheral neuropathy, and over time, this becomes difficult to continue therapy. In addition, giving bendamustine for more than 6 cycles can result in pretty significant long-term myelosuppression. In addition, however, to giving this for 6 cycles as a standalone palliative regimen, it's also been used frequently as a bridging approach to get patients to definitive therapy. And so this is one such study that was published last year, which looked at using polatuzumab vedotin with or without bendamustine rituximab to get patients to either CAR T or to potentially bridge patients to an allogeneic transplant. And you can see in the Kaplan-Meier curves on the bottom right here that a significant portion of patients were able to successfully get to CAR T and to enjoy prolonged overall survival. And so you can see that that over 50% of patients that were supposed to go to CAR T were ultimately able to do so with the polatuzumab vedotin as a bridging approach. And so, at least in my own practice, this is a common way that I employ this medication. In addition to polatuzumab vedotin, tafasitamab, which is a CD19-directed monoclonal antibody, is currently approved and utilized in the United States in combination with the immunomodulator lenalidomide. This was the L-MIND trial, which evaluated tafasitamab, initially given weekly and then every other week over time with lenalidomide. I would point out that the dose of lenalidomide in this study is 25 milligrams per day. This is the dose that's been felt to be most effective in patients with diffuse large B-cell lymphoma. I would comment, however, that this can be a difficult dose to use and to continue due to myelosuppression and other toxicities. And so often, if I'm going to use this regimen, I may, especially in an older patient who I'm not considering for more definitive therapy, I may start at a lower dose of lenalidomide, like 15 milligrams, and then potentially increase as tolerated. On this table, I've summarized the response data for the combination, including some patients that have higher risk disease. You can see that about 40% of patients achieve a complete response, with an additional 17% of patients achieving partial response. And so that's up to about 60% of patients who achieve some sort of objective response with the combination. And what's been particularly exciting is you can see that the median duration of response is actually quite good. So for those patients that do respond, you can see the median duration of response at the follow-up as of October 2020 was almost 4 years. And so for those patients that do respond, this can be associated with long-term remission. We do also see that there are responses seen in patients who are rituximab refractory or those that have primary refractory disease. And so again, this is a very active doublet that I do commonly use. On this update from last year, we can see that what is potentially most impactful with regards to duration of response is achieving a complete remission. So those patients that achieve a complete remission have a prolonged progression-free survival, whereas those that don't have a shorter progression-free and overall survival. In addition, I would highlight that there are some toxicities that have been identified with this combination. These are most commonly hematologic toxicities, although pneumonia has also been described. One key area of interest for this particular combination is that, or one key question is how this can be sequenced with CD19-directed CAR T therapy. So we know that CD19-directed CAR T therapy targets CD19, and so it stands to reason that administration of CAR T, of tafasitamab in patients who have recently received CAR T may not result in the same response. There have been some data suggesting that patients can still respond to CD19-directed therapy even after CAR T, although I typically don't include this as my first choice in a patient who's progressing after CAR T, just given the fact that they would have just progressed after a CD19-directed therapy. An additional CD19-directed treatment is loncastuximab tesirine, or Lonca-T. This is a CD19-directed antibody drug conjugate. This is the one study that included patients with relapsed refractory large cell lymphoma. In this study, patients receive an infusion once every 3 weeks. Similar to what we saw with the Tafa-Len combination, those patients who achieve a complete response enjoy a prolonged duration of response, whereas those who have a partial response don't seem to have the same duration. Now, one thing you can see here is that there aren't as many responders as we saw with the combination of tafasitamab and lenalidomide, so certainly something to keep in mind. We do also see cytopenias as well as an elevated GGT and other liver function abnormalities. And then one of the other specific toxicities associated with this particular agent is edema that can be potentially problematic and make it difficult to continue therapy. So this agent, I would say, is probably not used quite as frequently as the tafasitamab lenalidomide, but is still a very active therapy and certainly worth considering for patients with relapsed large cell lymphoma. Now, there are some other therapies and other considerations. So there are several bispecific antibodies that are in development, and I'll summarize these in a moment. We are still trying to figure out the best way to administer them, whether they should be given as monotherapy, whether they should be given in combination, either with chemo or with other novel agents. There are some, they are, all able to be given by IV, and some are also able to be administered subcutaneously. So I would say we're still very much early on in the time period for use of bispecific antibodies, but it's a very exciting new group of therapies. Allogeneic transplantation has been utilized and can be curative in some patients with relapsed refractory large cell lymphoma. At least in my own practice, I've been using this much less frequently than in the past. Typically, these are patients that have to have good control of their disease. And I would say that at least in my own experience, we've had better outcomes with CAR T, and I found it to be much less toxic and requiring much less long-term follow-up and management than allogeneic transplant. There are a number of chemotherapy regimens, more traditional chemotherapy regimens that can be used. I think the key here is just to make sure that you are accounting for quality of life in addition to clinical benefit. Some of the palliative chemotherapy regimens are very easy to tolerate, but may not be as effective. On the other hand, some of the more effective regimens may be a little bit less tolerable or may require hospitalization. In my own practice, I tend to not use a lot of chemotherapy in the relapse refractory setting outside of as a bridge to a cellular therapy, but certainly as a consideration. Some of the other oral targeted agents tend to be less effective. So ibrutinib and BTK inhibitors are not quite as effective in patients with relapsed disease. Rituximab plus lenalidomide is a potential option and can be effective in patients with relapse disease, but many of our other oral agents, the PI3 kinase inhibitors, venetoclax, tend to not be as effective. And it's very important to consider clinical trials when they're available throughout the entire course, and also to employ palliative care. So I have a lot of my patients that are seen by a palliative care physician in addition to seeing me. They're still on treatment, but they have a team that's helping to manage symptoms that develop. And if and when we do have to have a conversation about transitioning to comfort measures, it tends to be a much easier transition for patients and families when they've already been introduced to palliative care. So I think this is a really important component of management of patients with relapse disease. So this table summarizes some of the currently available, currently investigated bispecific antibodies. You can see that these are primarily being used in patients with diffuse large B-cell lymphoma, although several are also being evaluated in patients with low-grade lymphoma. We tend to see a very nice overall response rate with over half of patients responding. Some of you may recall the abstract from the plenary session at ASH in, I believe, 2019 with mosunetuzumab, which showed that there is a significant response rate even in patients who have progressed after CAR T, which historically has been a group of patients with a very poor prognosis. The bispecific antibodies are associated with some of the same toxicities as CAR T, specifically cytokine release syndrome, as well as neurologic toxicities. Fortunately, the severity of these toxicities tends to be less with the bispecific antibodies as opposed to CAR T, but they do require monitoring and active management. The other significant difference between CAR T and bispecifics is that the bispecifics are administered recurrently over a period of time, whereas CAR T is a single infusion. They don't require manufacturing. They're available off the shelf, and you don't have to have a cell therapy laboratory. So they're very appealing. And it will be interesting to see over time whether they take the place of CAR T in some instances or how they're sequenced with CAR T therapy. But these are very exciting, and I would expect that in the near future, we will have our first approval in the United States. Just a word about allogeneic transplantation. So as I mentioned, this has been utilized in the past, but I think needs to be considered for a very specific subset of patients. These would specifically be those patients that are young and healthy and that have had excellent response to second line or beyond, or to second line or beyond therapy. This is allogeneic transplant in my mind is not for a patient with refractory disease for whom you can't otherwise get control of their disease. On the left is a cohort analysis looking at patients who received either allogeneic transplant or CAR T. This is not meant to be a comparison. You can see, however, that there certainly are patients who have received allogeneic transplant who have had a prolonged response and had a prolonged overall survival. As I mentioned, this is a curative option in some patients. It's just important to keep in mind that you identify the right patients. It does appear, at least, that overall the outcomes seem to be a little bit better for those who received CAR T, but again, this was not meant to be a head-to-head comparison. On the right is a study looking at outcomes for patients who progress after CD19-directed CAR T and how they are treated. You can see that at least some of the patients have been treated with allogeneic transplant, and several have had ongoing responses at 12 months and beyond. You can see, however, that there's a wide range of different approaches. Unfortunately, all of these are associated with a poor overall survival, typically less than a year after a patient progresses after CAR T. So certainly an area where more investigation is needed. This may be a place where the bispecifics ultimately are administered, but allogeneic transplant can certainly be considered there, but really for the patients who have the best response to therapy and are particularly fit. So just some overall thoughts as we finish up. So despite advances, most patients with relapsed large cell lymphoma will not be cured. And so this is one reason that it's very important to try to maximize the cure rate in the front line. And so I know we've already heard about some of the different methods to do this, including the Polarix trial, which was recently presented, and may improve our outcome, or may improve the response duration for patients with large cell lymphoma. But again, I think a key aspect here is really to do what we can to cure as many patients as possible in the front line. Cell therapy approaches currently provide the best chance at cure, but I would still say that less than half of patients who get to one of these approaches will ultimately be cured of their disease. Traditional chemotherapy combinations are of limited utility, I would say, and are toxic. So this is certainly a consideration, but usually I like to think of this as a bridge to a more definitive therapy and not a standalone treatment in itself. Clinical trials, when available, are essential. Like I said, we still have not solved this problem. And in my own clinic, I continue to have patients coming in with early relapsing disease, or even those with later relapsing disease that will not respond as well as we would like to second-line therapy. And again, bispecific antibodies are very promising. I expect this will significantly change the way we think about management of relapse disease. And if I were to give this talk in a year, I suspect there'll be even more data available, and there may even be an approval. And so this is just my current approach for patients who are fit. As we heard before, I think from the last speaker, and again, as I would say, the timing of relapse is an important consideration. At least in my own practice, if a patient progresses within 12 months, I do try to get them to CAR T if they're otherwise eligible clinically. I recognize that this is something that may be available to us in the United States that may not be available everywhere at the current time. For those patients who have progressed after 12 months, I typically move forward with second-line therapy, usually a platinum-containing chemotherapy regimen. And then those who respond, I take to auto transplant. Those who do not respond, or those who go to auto transplant but subsequently relapse, I then try to get to CAR T. For patients who are unfit, I unfortunately would say that my approach doesn't fit as nicely into a flow sheet. I think that those are patients I try to think of for clinical trial. I try to think of balancing symptom palliation with toxicity and so forth, and that's a much more challenging situation. So again, I'd just like to thank you for the invitation. For those that many of you may have been to Atlanta for ASH, but for those that have not been to our campus, this is just an aerial view that I actually took myself on a trip pre-COVID on a nice day of our campus. So thank you very much again for the invitation. I hope everyone has a wonderful evening, and I'm happy to answer questions.
Thank you so much, Dr. Cohen, for taking us through this journey. We have a couple of our colleagues, and they may think of asking you some questions. We've been to your institute. Dr. Sagar Lonial from Myeloma Division is a good friend and colleague.
Oh, very good. Yes.
Yeah. He has come to India also a couple of times for the conferences.
Oh, very nice.
But they will be in a position to invite you as well.
Oh, I would love to. I'd love to.
Sure. So when the patients relapse, who exactly cannot go for CAR T therapy? Can I put a question other way?
Yeah, so that's a good question. So most patients that we see are potentially candidates for CAR T. The ones that we really struggle with are the patients that are really sick, that are very symptomatic, that we have to sort of admit into the hospital right away. For those patients, it can sometimes be challenging to get them to a place where we can hold chemotherapy long enough for them to go through the apheresis process. So that's one group. I would say that's the minority. Probably the biggest reason that patients don't go to CAR T, at least in our own practice, is some of the other comments I had made about logistics and psychosocial challenges. So maybe they live far away, maybe they don't have a caregiver, maybe they are not able to sort of manage the process of going through it, because there's a lot that's required of a patient. They have to go through a number of different procedures. They have to have a line placed and so forth. And so when I am meeting a new patient, one of the biggest aspects of that initial consultation, if we're thinking about CAR T, is trying to work with them to identify how best to navigate the process. That usually is a bigger challenge than the clinical issues.
And now that it has been around for a couple of years, can you put a figure like that? What percentage of patients are cured and they would not relapse?
Yeah, so it's a great question. So overall, if you look at the studies, it's probably been about 40% it will achieve a long-term remission. And whether they've been cured or not, I guess it's hard to say, but at least they're 5-6 years out and are still in remission. And so I think of those patients as likely being cured. In our own experience, I would say it's probably a little bit less than that, but it's more than 30%. I would say maybe about a third of our patients that I've taken care of sort of commercially, not on a study, have responded and stayed in remission. So compared to what we had to offer before, it's a dramatic change, but unfortunately that does mean that for 2/3 of patients, they go through this whole process and unfortunately the disease still comes back.
And if the patient is going for CAR T, you will avoid an antibody against CD19 in those patients before CAR T?
I typically do. Now, if somebody's already received it, I wouldn't prohibit them from getting CAR T. But if I have a choice, I typically try not to give them a CD19 directed antibody beforehand.
Okay. Other questions for Dr. Cohen? Dr. Krishna, Mukul, Kunal, Arihant? If there's anything in the chat box for you. Okay, so I think that's it. Thank you very much, Dr. Cohen, for being with us and educating us. We enjoyed listening to you. And
my pleasure. Take care. Absolutely. I hope to meet you in person. All right. Take care.
Bye-bye.
Bye-bye.
And good night to everybody from India. And we meet tomorrow at 6:25. Bye-bye.